Welcome to this video entitled Diabetes Mellitus. We will begin by discussing a few key concepts. 1. Diabetes mellitus is a group of metabolic disorders of fat, carbohydrate, and protein metabolism that results from defects in insulin secretion, insulin action, sensitivity, or both. 2. The incidence of type 2 diabetes mellitus, DM, is increasing. This has been attributed in part to increasing obesity, sedentary lifestyle, and an increasing minority population. 3. The two major classifications of diabetes mellitus are type 1, that is insulin deficient, and type 2, that is combined insulin resistance and relative deficiency in insulin secretion. They differ in clinical presentation, onset, etiology, and progression of disease. Both are associated with microvascular and macrovascular disease complications. 4. Diagnosis of diabetes mellitus is made by three criteria. Fasting plasma glucose of equal to or greater than 126 mg per deciliter, a 2-hour value from a 75-gram oral glucose tolerance test equal to or greater than 200 mg per deciliter, or a casual plasma glucose level of equal to or greater than 200 mg per deciliter with symptoms of diabetes mellitus, with results confirmed by any of the three criteria on a separate day. 5. Goals of therapy in diabetes mellitus are directed at reducing symptoms of hyperglycemia, reducing the onset and progression of retinopathy, nephropathy, and neuropathy complications, intensive therapy for associated cardiovascular risk factors, and improving quality and quantity of life. 6. Metformin should be included in the therapy for all type 2 diabetes mellitus patients, if tolerated and not contraindicated, as it is the only oral anti-hyperglycemic medication proven to reduce the risk of total mortality and cardiovascular death, according to the United Kingdom Prospective Diabetes Study. 7. Intensive glycemic control is paramount for reduction of microvascular complications, e.g. neuropathy, retinopathy, and nephropathy, as evidenced by the Diabetes Control and Complications Trial in Type 1 Diabetes Mellitus and the United Kingdom Prospective Diabetes Study, UKPDS, in Type 2 Diabetes Mellitus. The UKPDS also reported that control of hypertension in patients with diabetes will not only reduce the risk of retinopathy and nephropathy, but also reduce cardiovascular risk. 8. Knowledge of the patient's quantitative and qualitative meal patterns, activity levels, pharmacokinetics of insulin preparations, and pharmacology of oral anti-hyperglycemic agents are essential to individualize the treatment plan and optimize blood glucose control while minimizing risks for hypoglycemia and other adverse effects of pharmacologic therapies. 9. Type 1 treatment necessitates insulin therapy. Currently, the basal bolus insulin therapy or pump therapy in motivated individuals often leads to successful glycemic outcomes. Basal bolus therapy often includes a basal insulin for fasting and post-absorptive control, and rapid-acting bolus insulin for mealtime coverage. Therapeutically, use of basal bolus therapy in type 2 diabetes mellitus is increasing. 10. Treatment of type 2 diabetes mellitus often necessitates use of multiple therapeutic agents, combination therapy, including oral antihyperglycemics and insulin to obtain glycemic goals. 11. Aggressive management of cardiovascular disease risk factors in type 2 diabetes mellitus is necessary to reduce the risk for adverse cardiovascular events or death. Smoking cessation, use of antiplatelet therapy as a primary prevention strategy, aggressive management of dyslipidemia minimally to goal low-density lipoprotein cholesterol, LDL-C, less than 100 mg per deciliter, and secondarily to raise high-density lipoprotein cholesterol, HDLC, to equal to or greater than 40 mg per deciliter, and treatment of hypertension, again often requiring multiple drugs, minimally to less than 130 systolic 80 diastolic are vital. 12. Prevention strategies for type 1 diabetes mellitus have been unsuccessful. Prevention strategies for type 2 diabetes mellitus are established. Lifestyle changes, dietary restriction of fat, aerobic exercise for 30 minutes 5 times a week, and weight loss, form the backbone of successful prevention. To date, medications have been less effective than lifestyle changes to prevent progression to type 2 diabetes mellitus. 13. Patient education and ability to demonstrate self-care and adherence to therapeutic lifestyle and pharmacologic interventions are crucial to successful outcomes. Multidisciplinary teams of healthcare professionals including physicians, primary care, endocrinologists, ophthalmologists, and vascular surgeons, podiatrists, dietitians, nurses, pharmacists, social workers, behavioral health specialists, and certified diabetes educators are needed to optimize these outcomes in persons with diabetes mellitus. Diabetes mellitus is a group of metabolic disorders characterized by hyperglycemia, is associated with abnormalities in carbohydrate, fat and protein metabolism, and results in chronic complications including microvascular, macrovascular, and neuropathic disorders. Nearly 18.2 million Americans have diabetes mellitus, yet only about 2/3 of them have been diagnosed. The economic burden of diabetes mellitus approximated $132 billion in 2002, including direct medical and treatment costs as well as indirect costs attributed to disability and mortality. Diabetes mellitus is the leading cause of blindness in adults aged 20 to 74 years, and the leading contributor to development of end-stage renal disease. It also accounts for approximately 82,000 lower extremity amputations annually. Finally, a cardiovascular event is responsible for 75% of deaths in individuals with type 2 diabetes mellitus. Although efforts to control hyperglycemia and associated symptoms are important, the major challenges in optimally managing the patient with diabetes mellitus are targeted at reducing or preventing complications, and improving life expectancy and quality of life. Research and drug development efforts over the past several decades have provided valuable information that applies directly to improving outcomes in patients with diabetes mellitus and have expanded the therapeutic armamentarium. Additionally, interventions in an attempt to prevent disease in high-risk populations have been reported for type 1 and 2 diabetes mellitus. Next we will discuss the epidemiology of diabetes mellitus. Typical type 1 diabetes mellitus is an autoimmune disorder developing in childhood or early adulthood, although some latent forms do occur. Type 1 diabetes mellitus accounts for up to 10% of all cases of diabetes mellitus and is likely initiated by the exposure of a genetically susceptible individual to an environmental agent. Candidate genes and environmental factors are reportedly prevalent in the general population, but development of beta cell autoimmunity occurs in less than 10% of the population and progresses to diabetes mellitus in less than 1% of the population. The prevalence of beta cell autoimmunity appears proportional to the incidence of type 1 diabetes mellitus in various populations. For instance, the countries of Sweden, Sardinia, and Finland have the highest prevalence of islet cell antibody, in 3% to 4.5% cases, and are associated with the highest incidence of type 1 diabetes mellitus, 22 to 35 per 100,000. Markers of autoimmunity have been detected in 14% to 33% of persons with type 2 diabetes mellitus in some populations and manifest with early failure of oral agents and insulin dependence. This type of diabetes mellitus has also been referred to as latent autoimmune diabetes in adults, abbreviated as LADA. Type 1 diabetes mellitus idiopathic is a non-immune form of diabetes frequently seen in minorities with intermittent insulin requirements. The prevalence of type 1 diabetes mellitus has been increasing over the last 100 years. Maturity-onset diabetes of youth, abbreviated as MODY, which has an identifiable genetic defect in the glucokinase gene, and endocrine disorders such as acromegaly and Cushing's syndrome, can be secondary causes of diabetes mellitus. These unusual etiologies, however, only account for 1% to 2% of the total cases of type 2 diabetes mellitus. See the section on other forms of diabetes mellitus later in this chapter for further discussion. The prevalence of type 2 diabetes mellitus is increasing. Type 2 diabetes mellitus accounts for as much as 90% of all cases of diabetes mellitus, and overall the prevalence of type 2 diabetes mellitus in the United States is about 8.7% in persons age 20 or older. However, there is likely one person undiagnosed for every 2 persons currently diagnosed with the disease. Multiple risk factors for the development of type 2 diabetes mellitus have been identified, including family history, i.e., parents or siblings with diabetes, obesity, i.e., equal to or greater than 20% over ideal body weight, or body mass index, BMI, equal to or greater than 25 kg per meter squared, habitual physical inactivity, race or ethnicity, see list below, previously identified impaired glucose tolerance or impaired fasting glucose, hypertension equal to or greater than 140 systolic 90 diastolic in adults, high-density lipoprotein HDL, cholesterol equal to or less than 35 mg per deciliter and or a triglyceride level equal to or greater than 250 mg per deciliter, history of gestational diabetes mellitus or delivery of a baby weighing greater than 9 pounds, history of vascular disease, and polycystic ovary disease. The prevalence of type 2 diabetes mellitus increases with age. It is more common in women than in men in the United States, and varies widely among various racial and ethnic populations, being especially increased in some groups of Native Americans, Hispanic American, Asian American, African American, and Pacific Island people as shown in figures 72.1 and 72.2. While the prevalence of type 2 diabetes mellitus increases with age, the disorder is increasingly being recognized in adolescence. Much of the rise in adolescent type 2 diabetes mellitus is related to an increase in adiposity and sedentary lifestyle, in addition to an inheritable predisposition. Most cases of type 2 diabetes mellitus do not have a well-known cause. Therefore it is uncertain whether it represents a few or many independent disorders manifesting as hyperglycemia. With increasing worldwide obesity, the prevalence of type 2 diabetes mellitus is increasing, though this has been recently disputed, suggesting that we are primarily just finding more cases through more aggressive screening. Gestational diabetes mellitus, abbreviated as GDM, complicates roughly 7% of all pregnancies in the United States. Most women will return to normoglycemia postpartum, but 30% to 50% will develop type 2 diabetes mellitus or glucose intolerance later in life. Pause the video and carefully scrutinize Figure 72.1 summarizing percentage of the population with diagnosed diabetes by age for the period 1991 to 1993 before advancing to the next slide. Pause the video and carefully scrutinize Figure 72.2 summarizing the prevalence of diabetes mellitus in ages 45 to 74 years, in U.S. whites and blacks from 1976 till 1980, and Latinos from 1982 till 1984, before advancing to the next slide. We will now look at the pathogenesis, diagnosis, and classification of diabetes mellitus. Let's begin with the classification of diabetes mellitus. Diabetes mellitus is a metabolic disorder characterized by resistance to the action of insulin, insufficient insulin secretion, or both. The clinical manifestation of these disorders is hyperglycemia. The vast majority of diabetic patients are classified into one of two broad categories. Type 1 diabetes mellitus caused by an absolute deficiency of insulin, or type 2 diabetes mellitus defined by the presence of insulin resistance with an inadequate compensatory increase in insulin secretion. Women who develop diabetes mellitus due to the stress of pregnancy are classified as having gestational diabetes. Finally, uncommon types of diabetes mellitus caused by infections, drugs, endocrinopathies, pancreatic destruction, and known genetic defects are classified separately, as shown in Table 72.1. Let's now discuss Type 1 diabetes mellitus. This form of diabetes results from autoimmune destruction of the beta cells of the pancreas. Markers of immune destruction of the beta cell are present at the time of diagnosis in 90% of individuals and include islet cell antibodies, antibodies to glutamic acid decarboxylase, and antibodies to insulin. While this form of diabetes usually occurs in children and adolescents, it can occur at any age. Younger individuals typically have a rapid rate of beta cell destruction and present with ketoacidosis, while adults often maintain sufficient insulin secretion to prevent ketoacidosis for many years, which is often referred to as latent autoimmune diabetes in adults, abbreviated as LADA. We will now look at type 2 diabetes mellitus. This form of diabetes is characterized by insulin resistance and, at least initially, a relative lack of insulin secretion. Most individuals with type 2 diabetes mellitus exhibit abdominal obesity, which itself causes insulin resistance. In addition, hypertension, dyslipidemia, that is high triglyceride levels and low HDL cholesterol levels, and elevated inhibitor plasminogen activator 1, abbreviated as PAI1, levels are often present in these individuals. This clustering of abnormalities is referred to as the insulin resistance syndrome, or the metabolic syndrome. Because of these abnormalities, patients with type 2 diabetes mellitus are at increased risk of developing macrovascular complications. Type 2 diabetes mellitus has a strong genetic predisposition and is more common in all ethnic groups other than those of European ancestry. At this point, the genetic cause of most cases of type 2 diabetes mellitus is not well defined. We will now look at gestational diabetes mellitus. Gestational diabetes mellitus, abbreviated as GDM, is defined as glucose intolerance which is first recognized during pregnancy. Gestational diabetes complicates about 7% of all pregnancies. Clinical detection is important, as therapy will reduce perinatal morbidity and mortality. And now we will discuss other specific types of diabetes mellitus. Let's look at genetic defects. Maturity-onset diabetes of youth, abbreviated as MODY, is characterized by impaired insulin secretion with minimal or no insulin resistance. Patients typically exhibit mild hyperglycemia at an early age. The disease is inherited in an autosomal dominant pattern with at least 3 different loci identified to date. Genetic inability to convert proinsulin to insulin results in mild hyperglycemia and is inherited in an autosomal dominant pattern. Similarly, The production of mutant insulin molecules has been identified in a few families and results in mild glucose intolerance. Several genetic mutations have been described in the insulin receptor and are associated with insulin resistance. Type A insulin resistance refers to the clinical syndrome of acanthosis nigricans, virilization in women, polycystic ovaries, and hyperinsulinemia. Leprechaunism is a pediatric syndrome with specific facial features and severe insulin resistance due to a defect in the insulin receptor gene. Lipotrophic diabetes mellitus probably results from post-receptor defects in insulin signaling. We will now look at gestational diabetes mellitus. Gestational diabetes mellitus, abbreviated as GDM, is defined as glucose intolerance which is first recognized during pregnancy. Gestational diabetes complicates about 7% of all pregnancies. Clinical detection is important, as therapy will reduce perinatal morbidity and mortality. And now we will discuss other specific types of diabetes mellitus. Let's look at genetic defects. Maturity-onset diabetes of youth, abbreviated as MODY, is characterized by impaired insulin secretion with minimal or no insulin resistance. Patients typically exhibit mild hyperglycemia at an early age. The disease is inherited in an autosomal dominant pattern with at least 3 different loci identified to date. Genetic inability to convert proinsulin to insulin results in mild hyperglycemia and is inherited in an autosomal dominant pattern. Similarly, the production of mutant insulin molecules has been identified in a few families and results in mild glucose intolerance. Several genetic mutations have been described in the insulin receptor and are associated with insulin resistance. Type A insulin resistance refers to the clinical syndrome of acanthosis nigricans, virilization in women, polycystic ovaries, and hyperinsulinemia. Leprechaunism is a pediatric syndrome with specific facial features and severe insulin resistance due to a defect in the insulin receptor gene. Lipotrophic diabetes mellitus probably results from post-receptor defects in insulin signaling. We will now briefly look at children and adolescents. Despite a lack of clinical evidence to support widespread testing of children for type 2 diabetes mellitus, it is clear that more children and adolescents are developing type 2 diabetes mellitus. The ADA recommends that overweight defined as BMI greater than the 85th percentile for age and sex, weight for height greater than the 85th percentile, or weight greater than 120% of ideal 50th percentile, for height, youths with at least 2 of the following risk factors. A family history of type 2 diabetes mellitus in first and second degree relatives, Native Americans, African Americans, Hispanic Americans, and Asians or South Pacific Islanders, and those with signs of insulin resistance or conditions associated with insulin resistance, acanthosis nigricans, hypertension, dyslipidemia, or polycystic ovary syndrome, be screened. Testing should be done every 2 years starting at 10 years of age or at the onset of puberty if it occurs at a younger age. Next we will look at gestational diabetes mellitus. Risk assessment for gestational diabetes mellitus should occur at the first prenatal visit. Women at high risk, positive family history, history of gestational diabetes mellitus, marked obesity, or member of a high-risk ethnic group, should be screened as soon as feasible. If the initial screening is negative, they should undergo retesting at 24 to 28 weeks gestation. Evaluation for gestational diabetes mellitus can be done in one of 2 ways. The one-step approach involves an oral glucose tolerance test only and may be cost-effective in high-risk patient populations. The 2-step approach uses a screening test to measure plasma or serum glucose concentration 1 hour after a 50-gram oral glucose load, glucose challenge test, abbreviated as GCT, followed by a diagnostic oral glucose tolerance test on the subset of women exceeding a glucose threshold of either greater than 140 mg per deciliter, that is 80% sensitive, or greater than 130 mg per deciliter, that is 90% sensitive. The diagnosis of gestational diabetes mellitus is based on a 75-gram, not as well validated, or 100-gram oral glucose tolerance test. Criteria for diagnosis of gestational diabetes mellitus based on the oral glucose tolerance test are summarized in Table 72.2. Pause the video and carefully scrutinize Table 72.1 summarizing the etiologic classification of diabetes mellitus before advancing to the next slide. Pause the video and carefully scrutinize Table 72.1 summarizing the etiologic classification of diabetes mellitus before advancing to the next slide. Pause the video and carefully scrutinize Table 72.2 summarizing the diagnosis of gestational diabetes mellitus with a 100-gram or 75-gram glucose load before advancing to the next slide. Pause the video and carefully scrutinize Table 72.3 summarizing the criteria for the diagnosis of diabetes mellitus before advancing to the next slide. Pause the video and carefully scrutinize Table 72.4 summarizing the categorization of glucose status before advancing to the next slide. Next we will discuss the diagnosis of diabetes mellitus. The diagnosis of diabetes mellitus requires the identification of a glycemic cut point, which discriminates normals from diabetics, as shown in Table 72.3. The present cut points reflect the level of glucose above which microvascular complications have been shown to increase. Cross-sectional studies from Egypt, in Pima Indians, and in a representative sample from the United States have shown a consistent increase in the risk of developing retinopathy at a fasting glucose level above 99 to 116 mg per deciliter, that is 5.5 to 6.4 millimoles per liter, at a 2-hour postprandial level above 125 to 185 mg per deciliter, that is 6.9 to 10.3 millimoles per liter, and a hemoglobin A1C, abbreviated as HbA1c, above 5.9 to 6.0%, as shown in Figure 72.3. The ADA recommends using the fasting glucose as the principal tool for the diagnosis of diabetes mellitus in non-pregnant adults. In addition, as shown in Table 72.4, they defined a new category of glycemia, impaired fasting glucose, abbreviated as IFG. Impaired fasting glucose is a plasma glucose of at least 100 mg per deciliter, 5.6 mmol/L, but less than 126 mg per deciliter, that is 7.0 millimoles per liter. This category corresponds to the category of impaired glucose tolerance, abbreviated as IGT, defined as a 2-hour glucose value equal to or greater than 140 mg per deciliter, that is 7.8 millimoles per liter, but less than 200 mg per deciliter, that is 11.0 millimoles per liter, during an oral glucose tolerance test. Patients with either impaired fasting glucose or impaired glucose tolerance are now commonly referred to as having prediabetes, due to a higher risk of developing diabetes in the future. The fasting and postprandial glucose levels do not measure the same physiologic processes and do not identify the same individuals as having diabetes. The fasting glucose reflects hepatic glucose production, which depends on insulin secretory capacity of the pancreas. The postprandial glucose reflects uptake of glucose in peripheral tissues, muscle and fat, and depends on insulin sensitivity of these tissues. The ADA recommends use of hemoglobin A1C determinations to monitor glycemic control in known diabetic patients. Because there is no gold standard assay and several countries do not have ready access to the test, a hemoglobin A1C determination is not recommended to diagnose diabetes at the present time. Next we will discuss the pathogenesis. Type 1 diabetes mellitus. Type 1 diabetes mellitus is characterized by an absolute deficiency of insulin. Most often this is the result of an immune-mediated destruction of pancreatic beta cells, but rare unknown or idiopathic processes may contribute. What is evident are four main features. 1. A long preclinical period marked by the presence of immune markers when beta cell destruction is thought to occur. 2. Hyperglycemia when 80% to 90% of beta cells are destroyed. 3. Transient remission, the so-called honeymoon phase. And 4. Established disease with associated risks for complications and death. Unknown is whether there is one or more inciting factors, e.g., cow's milk, or viral, dietary, or other environmental exposure, that initiate the autoimmune process, as shown in Figure 72.4. The autoimmune process is mediated by macrophages and T lymphocytes with circulating autoantibodies to various beta cell antigens. The most commonly detected antibody associated with type 1 diabetes mellitus is the islet cell antibody. The test for islet cell antibody, however, is difficult to standardize across laboratories. Other more readily measured circulating antibodies include insulin autoantibodies, antibodies directed against glutamic acid decarboxylase, insulin antibodies against islet tyrosine phosphatase, and several others. More than 90% of newly diagnosed persons with type 1 diabetes mellitus have one or another of these antibodies, as will 3.5% to 4% of unaffected first-degree relatives. Preclinical beta cell autoimmunity precedes the diagnosis of type 1 diabetes mellitus by up to 9 to 13 years. Autoimmunity may remit in some perhaps less susceptible persons, or can progress to beta cell failure in others. These antibodies are generally considered markers of disease rather than mediators of beta cell destruction. They have been used to identify individuals at risk for type 1 diabetes mellitus in evaluating disease prevention strategies. Other non-pancreatic autoimmune disorders are associated with type 1 diabetes mellitus, most commonly Hashimoto's thyroiditis, but the extent of organ involvement can range from no other organs to polyglandular failure. There are strong genetic linkages to the DQA and B genes, and certain human leukocyte antigens, abbreviated as HLAs, may be predisposing DR3 and DR4, or protective DRB1*04008 to DQB1*0302 and DRB1*0411 to DQB1*0302, on chromosome 6. Other candidate gene regions have been identified on several other chromosomes as well. Because twin studies do not show 100% concordance, environmental factors such as infectious agents, chemical agents, and dietary agents are likely contributing factors in the expression of the disease. Pause the video and carefully scrutinize Figure 72.3 illustrating the prevalence of retinopathy by deciles of the distribution of fasting plasma glucose, 2-hour postprandial glucose, and hemoglobin A1C in Pima Indians before advancing to the next slide. Pause the video and carefully scrutinize Figure 72.3 illustrating the prevalence of retinopathy by deciles of the distribution of fasting plasma glucose, 2-hour postprandial glucose, and hemoglobin A1C in Egyptians before advancing to the next slide. Pause the video and carefully scrutinize Figure 72.3 illustrating the prevalence of retinopathy by deciles of the distribution of fasting plasma glucose, 2-hour postprandial glucose, and hemoglobin A1C in 40 to 74-year-old participants in National Health and Nutrition Examination Survey before advancing to the next slide. Pause the video and carefully scrutinize Figure 72.4 illustrating a scheme of the natural history of the beta cell defect in type 1 diabetes mellitus before advancing to the next slide. Pause the video and carefully scrutinize Figure 72.5 illustrating whole body glucose disposal. A measure of insulin resistance is reduced 40% to 50% in obese non-diabetic and lean type 2 diabetic individuals before advancing to the next slide. Next we will discuss type 2 diabetes mellitus. Normal insulin action in the fasting state. 75% of total body glucose disposal takes place in non-insulin dependent tissues, the brain and splanchnic tissues, liver and gastrointestinal tissues. In fact, brain glucose uptake occurs at the same rate during fed and fasting periods and is not altered in type 2 diabetes mellitus. The remaining 25% of glucose metabolism takes place in muscle, which is dependent on insulin. In the fasting state, approximately 85% of glucose production is derived from the liver, and the remaining amount is produced by the kidney. In the fed state, carbohydrate ingestion increases the plasma glucose concentration and stimulates insulin release from the pancreatic beta cells. The resultant hyperinsulinemia 1. suppresses hepatic glucose production and 2. stimulates glucose uptake by peripheral tissues. The majority, that is approximately 80% to 85%, of glucose that is taken up by peripheral tissues is disposed of in muscle with only a small amount, that is approximately 4% to 5%, being metabolized by adipocytes. Although fat tissue is responsible for only a small amount of total body glucose disposal, it plays a very important role in the maintenance of total body glucose homeostasis. Small increments in the plasma insulin concentration exert a potent antilipolytic effect, leading to a marked reduction in the plasma-free fatty acid, abbreviated as FFA, level. The decline in plasma-free fatty acid concentration results in increased glucose uptake in muscle and reduces hepatic glucose production. Thus, a decrease in the plasma-free fatty acid concentration lowers plasma glucose by both decreasing its production and enhancing the uptake in muscle. Type 2 diabetic individuals are characterized by 1. defects in insulin secretion, and 2. insulin resistance involving muscle, liver, and the adipocyte. Insulin resistance is present even in lean type 2 diabetic individuals, as shown in Figure 72.5. Next we will discuss impaired insulin secretion. The pancreas in people with a normal functioning beta cell is able to adjust its secretion of insulin to maintain normal glucose tolerance. Thus, in non-diabetic individuals, insulin is increased in proportion to the severity of the insulin resistance and glucose tolerance remains normal. Impaired insulin secretion is a uniform finding in type 2 diabetic patients, and the evolution of beta cell dysfunction has been well characterized in diverse ethnic populations. DiFronzo and colleagues measured the fasting plasma insulin concentration and performed oral glucose tolerance tests in 77 normal weight type 2 diabetic patients and over 100 lean subjects with normal or impaired glucose tolerance, as shown in Figure 72.6. The relationship between the fasting plasma glucose concentration and the fasting plasma insulin concentration resembles an inverted U or horseshoe. As the fasting plasma glucose concentration rises from 80 to 140 mg per deciliter, the fasting plasma insulin concentration increases progressively, peaking at a value that is 2 to 2.5-fold greater than in normal weight non-diabetic controls. When the fasting plasma glucose concentration exceeds 140 mg per deciliter, the beta cell is unable to maintain its elevated rate of insulin secretion and the fasting insulin concentration declines precipitously. This decrease in fasting insulin leads to an increase in hepatic glucose production overnight, which results in an elevated fasting plasma glucose concentration. Pause the video and carefully scrutinize Figure 72.6 illustrating the relationship between fasting plasma insulin and fasting plasma glucose in 177 normal weight individuals before advancing to the next slide. Next we will discuss the site of insulin resistance in type 2 diabetes mellitus. We will begin with the liver. In type 2 diabetic subjects with mild to moderate fasting hyperglycemia, that is 140 to 200 mg per deciliter, that is 7.8 to 11.1 millimoles per liter, basal hepatic glucose production is increased by approximately 0.5 mg per kilogram per minute. Consequently, during the overnight sleeping hours, the liver of an 80 kg diabetic individual with modest fasting hyperglycemia adds an additional 35 grams of glucose to the systemic circulation. This increase in fasting hepatic glucose production is the cause of fasting hyperglycemia. Following glucose ingestion, insulin is secreted into the portal vein and carried to the liver, where it suppresses hepatic glucose output. If the liver is resistant to insulin and continues to produce glucose, there will be two inputs of glucose into the body, one from the liver and another from the gastrointestinal tract, and marked hyperglycemia will ensue. We will now consider the peripheral, that is muscle, site. Muscle is the major site of glucose disposal in man, and approximately 80% of total body glucose uptake occurs in skeletal muscle. In response to a physiologic increase in plasma insulin concentration, muscle glucose uptake increases linearly, reaching a plateau value of 10 mg per kilogram per minute. In contrast, in lean type 2 diabetic subjects, the onset of insulin action is delayed for approximately 40 minutes, and the ability of insulin to stimulate leg glucose uptake is reduced by 50%. Therefore, the primary site of insulin resistance in type 2 diabetic subjects resides in muscle tissue. We will now consider peripheral, that is adipocyte site. In obese non-diabetic and diabetic humans, basal plasma free fatty acid levels are increased and fail to suppress normally after glucose ingestion. Free fatty acids are stored as triglycerides in adipocytes and serve as an important energy source during conditions of fasting. Insulin is a potent inhibitor of lipolysis, and restrains the release of free fatty acids from the adipocyte by inhibiting the hormone-sensitive lipase enzyme. It is now recognized that chronically elevated plasma-free fatty acid concentrations can lead to insulin resistance in muscle and liver and impair insulin secretion. In addition to free fatty acids that circulate in plasma in increased amounts, type 2 diabetic and obese non-diabetic individuals have increased stores of triglycerides in muscle and liver, and the increased fat content correlates closely with the presence of insulin resistance in these tissues. In summary, insulin resistance involving both muscle and liver are characteristic features of the glucose intolerance in type 2 diabetic individuals. In the basal state, the liver represents a major site of insulin resistance, and this is reflected by overproduction of glucose. This accelerated rate of hepatic glucose output is the primary determinant of the elevated fasting plasma glucose concentration in type 2 diabetic individuals. In the fed state, both decreased muscle glucose uptake and impaired suppression of hepatic glucose production contribute to the insulin resistance. In obese individuals and in the majority, greater than 80%, of type 2 diabetic subjects, There is an expanded fat cell mass and the adipocytes are resistant to the antilipolytic effects of insulin. Most obese and diabetic individuals are characterized by expanded visceral adiposity, discussed in detail later in the chapter, which is especially refractory to insulin effects and results in a high lipolytic rate. Not surprisingly, both type 2 diabetes and obesity are characterized by an elevation in the mean 24-hour plasma-free fatty acid concentration. Elevated plasma-free fatty acid levels, as well as increased triglyceride fatty acyl-CoA content in muscle, liver, and beta cells, led to the development of muscle hepatic insulin resistance and impaired insulin secretion. Next we will discuss the cellular mechanisms of insulin resistance. Insulin resistance and the components of the insulin resistance syndrome are described below. Obesity and insulin resistance. Weight gain leads to insulin resistance, and obese non-diabetic individuals have the same degree of insulin resistance as lean type 2 diabetic patients. In 1,146 non-diabetic, normotensive individuals, Ferranini and associates showed a progressive loss of insulin sensitivity when the BMI increased from 18 kg per meter squared to 38 kg per meter squared. The increase in insulin resistance with weight gain is directly related to the amount of visceral adipose tissue. The term visceral adipose tissue, abbreviated as VAT, refers to fat cells located within the abdominal cavity and includes omental, mesenteric, retroperitoneal, and perinephric adipose tissue. Visceral adipose tissue has been shown to correlate with insulin resistance and explain much of the variation in insulin resistance seen in a population of African Americans. Visceral adipose tissue represents 20% of fat in men and 6% of fat in women. This fat tissue has been shown to have a higher rate of lipolysis than subcutaneous fat, resulting in an increase in free fatty acid production. These fatty acids are released into the portal circulation and drain into the liver, where they stimulate the production of very low-density lipoproteins and decrease insulin sensitivity in peripheral tissues. Visceral adipose tissue also produces a number of cytokines which cause insulin resistance. These factors drain into the portal circulation and reduce insulin sensitivity in peripheral tissues. The fat cell also has the capability of producing at least one hormone that improves insulin sensitivity, adiponectin. This factor is made in decreasing amounts as an individual becomes more obese. In animal models, adiponectin decreases hepatic glucose production and increases fatty acid oxidation in muscle. Next we will discuss the metabolic syndrome. The association of insulin resistance with a clustering of cardiovascular risk factors including hyperinsulinemia, hypertension, abdominal obesity, dyslipidemia, and coagulation abnormalities has been referred to by a variety of names including the insulin resistance syndrome, the metabolic syndrome, the dysmetabolic syndrome, and the deadly quartet, to name a few. Since the description of the insulin resistance syndrome by Revan in 1988, the number of associated factors has continued to grow. The most widely used criteria to define this syndrome were published as part of the National Cholesterol Education Program Adult Treatment Panel, abbreviated as NCEP-ATP, 3 guidelines for the treatment of hypercholesterolemia. The NCEP components of the metabolic syndrome are outlined in Table 72.5. The ATP guidelines establish a diagnosis of the metabolic syndrome when at least 3 of the 5 criteria are present. The metabolic syndrome has been assigned the diagnostic code 277.7 by the International Classification of Diseases, 9th revision, which enables reimbursement for treating patients with this condition. The standard for the individual risk factors vary between NCEP-ATP and other expert panels including the World Health Organization and the American College of Endocrinology. For example, NCEP-ATP uses waist circumference to define obesity, while other expert committees use the Body Mass Index (BMI). The ATP guidelines base glucose intolerance on a fasting glucose while others prefer the results of an oral glucose tolerance test. As we are better able to quantify the relationship between these factors and the development of cardiovascular disease, the definition of the syndromes and the individual component values will no doubt continue to be refined. Pause the video and carefully scrutinize Table 72(5) summarizing the 5 components of the metabolic syndrome before advancing to the next slide. We will now discuss the prevalence of insulin resistance syndrome. The insulin resistance syndrome, abbreviated as IRS, is common in the United States. Ford and colleagues analyzed the data from the Third National Health and Nutrition Evaluation Survey, abbreviated as NHANES3, carried out in 1988 to 1994. The sample included 20,050 persons aged 17 years and over, with glucose tolerance testing performed in 3,302 persons aged 40 to 74 years. 26% of this population had 3 or more of the metabolic abnormalities defined by the NCEP-ATP. The prevalence of the insulin resistance syndrome increases with age, with 33% affected at age 40, 40% at age 50, and 50% by 60 years of age. The prevalence of the insulin resistance syndrome also differs in various ethnic groups, with 52% of Mexican Americans affected, compared to 36% of African Americans and 40% of Caucasians. The impact of treating the clinical components of the metabolic syndrome was demonstrated in the STENO-2 study. In this prospective study, 63 patients with diabetes mellitus and microalbuminuria were randomized to the usual therapy group and 67 patients were treated intensively. Intensive therapy consisted of diet and exercise and pharmacologic intervention aimed at hyperglycemia, hypertension, dyslipidemia, microalbuminuria, and increased coagulopathy, aspirin therapy. Treatment goals for intensive therapy included a blood pressure less than 130 systolic 80 diastolic, HB, A1C less than 6.5%, total cholesterol less than 175 mg per deciliter, and triglycerides less than 150 mg per deciliter. All patients in the intensive treatment group were given an aspirin and treated with an angiotensin-converting enzyme inhibitor. Patients in the intensively treated group showed a 53% reduction in cardiovascular disease and a 61% reduction in nephropathy. The magnitude of this reduction is greater than has been demonstrated with individual interventions, stressing the importance of targeting all the components of the metabolic syndrome. The study design did not allow conclusions regarding which interventions had the most impact. Next we will discuss clinical presentation of diabetes mellitus. The clinical presentations of type 1 diabetes mellitus and type 2 diabetes mellitus are very different, as shown in Table 72(6). Autoimmune type 1 diabetes mellitus can occur at any age. Approximately 75% will develop the disorder before age 20 years, but the remaining 25%, including relatives of index patients, develop the disease as adults. Individuals with type 1 diabetes mellitus are often thin and are prone to develop diabetic ketoacidosis if insulin is withheld, or under conditions of severe stress with an excess of insulin counterregulatory hormones. 20 to 40% of patients with type 1 diabetes mellitus present with diabetic ketoacidosis after several days of polyuria, polydipsia, polyphagia, and weight loss. Occasionally, patients are diagnosed as short of metabolic bankruptcy when they have blood tests drawn for other reasons or for early symptoms. Because newly diagnosed patients with type 1 diabetes mellitus often have a small amount of residual pancreatic beta cell function, they may enter a honeymoon phase, when their blood glucose concentrations are relatively easy to control and small amounts of insulin are needed. Once this residual insulin secretion wanes, the patients are completely insulin deficient and have more labile glycemia. Patients with type 2 diabetes mellitus often present without symptoms, even though complications tell us that they may have had type 2 diabetes mellitus for several years. Often these patients are diagnosed secondary to unrelated blood testing. Lethargy, polyuria, nocturia, and polydipsia can be seen at diagnosis in type 2 diabetes mellitus, but significant weight loss at diagnosis is less common. Pause the video and carefully scrutinize Table 72-6 summarizing the clinical presentation of diabetes mellitus before advancing to the next slide. Next we will discuss the treatment of diabetes mellitus. We will begin with desired outcome. The primary goals of diabetes mellitus management are to reduce the risk for microvascular and macrovascular disease complications, to ameliorate symptoms, to reduce mortality, and to improve quality of life. Near normal glycemia will reduce the risk for development of microvascular disease complications, but current evidence targets aggressive management of traditional cardiovascular risk factors, i.e., smoking cessation, treatment of dyslipidemia, intensive blood pressure control, and antiplatelet therapy, to reduce the likelihood of development of macrovascular disease. Hyperglycemia not only increases the risk for microvascular disease, but contributes to poor wound healing, compromises white blood cell function, and leads to classic symptoms of diabetes mellitus. Diabetic ketoacidosis and hyperosmolar hyperglycemic state are severe manifestations of poor diabetes control, invariably requiring hospitalization. Reducing the potential for microvascular complications is targeted at adherence to therapeutic lifestyle intervention, i.e., diet and exercise programs, and drug therapy regimens, as well as at maintaining blood pressure as near normal as possible. We will now look at the general approach to treatment. Appropriate care requires goal setting for glycemia, blood pressure, and lipid levels, regular monitoring for complications, dietary and exercise modifications, medications, appropriate self-monitoring of blood glucose, abbreviated as SMBG, and laboratory assessment of the aforementioned parameters. Glucose control alone does not sufficiently reduce the risk of complications in persons with diabetes mellitus. We will now look at glycemic goal setting and the hemoglobin A1c. Controlled clinical trials provide ample evidence that glycemic control is paramount in reducing microvascular complications in both type 1 diabetes mellitus and type 2 diabetes mellitus. HbA1c measurements are the gold standard for following long-term glycemic control for the previous 3 months. Hemoglobinopathies, anemia, and red cell membrane defects can affect HbA1c measurements. Other strategies, e.g., measurement of fructosamine, may be necessary to assess diabetes control in these patients. Unless the risk outweighs the benefit, as in elderly patients, patients with advanced complications, and patients with other advanced disease, an HbA1c target of less than 7% is appropriate, as shown in Table 72-7, and lower values may be targeted if significant hypoglycemia and/or weight gain can be avoided. Next we will discuss monitoring complications. The ADA recommends initiation of complications monitoring at the time of diagnosis of diabetes mellitus. Current recommendations continue to advocate yearly dilated eye examinations in type 2 diabetes mellitus, and an initial eye exam in the first 3 to 5 years in type 1 diabetes mellitus, then yearly thereafter. Less frequent testing, every 2 to 3 years, can be implemented upon the advice of an eye care specialist. The feet should be examined and the blood pressure should be assessed at each visit. A urine test for microalbumin once yearly is appropriate. Yearly testing for lipid abnormalities, and more frequently if needed to achieve lipid goals, is recommended. And now we will discuss self-monitoring of blood glucose. The advent of self-monitoring of blood glucose in the early 1980s revolutionized the treatment of diabetes mellitus, enabling patients to know their blood glucose concentration at any moment easily and relatively inexpensively. Frequent self-monitoring of blood glucose is necessary to achieve near normal blood glucose concentrations and to assess for hypoglycemia, particularly in patients with type 1 diabetes mellitus. The more intense the insulin regimen is, the more intense the self-monitoring of blood glucose needs to be, 4 or more times daily in patients on multiple insulin injections or pump therapy. The utility and optimal frequency of self-monitoring of blood glucose for patients with type 2 diabetes mellitus is unresolved. Frequency of monitoring in type 2 diabetes mellitus should be sufficient to facilitate reaching glucose goals. The role of self-monitoring of blood glucose in improving glycemic control in type 2 diabetes mellitus patients is unproven. Patients must be empowered to change their therapeutic regimen, lifestyle and medications, in response to test results, or no meaningful change is likely to be affected. Pause the video and carefully scrutinize Table 72(7) summarizing glycemic goals of therapy before advancing to the next slide. We will now discuss a clinical controversy. Though recommended by most diabetes clinicians, few well-conducted studies have shown positive correlations with home blood glucose testing for type 2 diabetes mellitus. Also, at least one study saw no effect with reduction in average testing, as the HbA1c did not deteriorate. Patients must be empowered to change their therapeutic regimen, that is lifestyle and medications, in response to test results, or no meaningful change is likely to be affected, and thus the money spent on the strip is wasted. Next we will discuss non-pharmacologic therapy. We will begin with diet. Medical nutrition therapy is recommended for all persons with diabetes mellitus. Paramount for all medical nutrition therapy is the attainment of optimal metabolic outcomes and the prevention and treatment of complications. For individuals with type 1 diabetes mellitus, the focus is on regulating insulin administration with a balanced diet to achieve and maintain a healthy body weight. Although still debated, most people with diabetes require a meal plan that is moderate in carbohydrates and low in saturated fat, with a focus on balanced meals. It is imperative that patients understand the connection between carbohydrates and glucose control. In addition, patients with type 2 diabetes mellitus often require caloric restriction to promote weight loss. Rather than a set diabetic diet, advocate a diet using foods that are within the financial reach and cultural milieu of the patient. Bedtime and between meals snacks are not usually needed if pharmacologic management is appropriate. We will now discuss a clinical controversy. The recommended daily carbohydrate intake for type 2 diabetes mellitus, and even type 1 diabetes mellitus, has become controversial since low-carbohydrate diets such as the Atkins, South Beach, and carbohydrate addicts diets have become exceptionally popular. Currently, the ADA recommends that approximately 60% to 70% of daily caloric intake should come from carbohydrates and monounsaturated fat. Many clinicians are trying to increase the monounsaturated fat percentage and decrease the carbohydrate percentage in a patient's diet to accomplish improved glycemic control. Recent studies have also documented short-term success for weight loss on low-carbohydrate diets, without deleterious effects on the lipid panel. Weight loss can reduce cardiovascular risk factors in type 2 diabetes mellitus. We will now look at activity. In general, most patients with diabetes mellitus can benefit from increased activity. Aerobic exercise improves insulin resistance and glycemic control in the majority of individuals, and reduces cardiovascular risk factors, contributes to weight loss or maintenance, and improves well-being. The patient should choose an activity that she or he is like to continue. Start exercise slowly in previously sedentary patients. Older patients, patients with long-standing disease, age greater than 35 years, or greater than 25 years with diabetes mellitus for longer than 10 years, patients with multiple cardiovascular risk factors, presence of microvascular disease, and patients with previous evidence of atherosclerotic disease should have a cardiovascular evaluation, probably including a graded exercise test with imaging, prior to beginning a moderate to intense exercise regimen. In addition, several complications, autonomic neuropathy, insensate feet, and retinopathy, may require restrictions on the activities recommended. Next we will discuss pharmacologic therapy. Until 1995, only two options for pharmacologic treatment were available for patients with diabetes: sulfonylureas for type 2 diabetes mellitus only, and insulin for type 1 or 2. After 1995, a number of new oral agents and insulins have been introduced in the United States. Currently, 5 classes of oral agents are approved for the treatment of type 2 diabetes: alpha-glucosidase inhibitors, biguanides, meglitinides, peroxime proliferator activated receptor gamma agonists, which are also commonly identified as thiazolidinedione or glitazones, and sulfonylureas. Oral agents are indicated for use in type 2 diabetes mellitus patients who are unable to achieve glycemic control goals despite diet and exercise. Oral antidiabetic agents are often grouped according to their glucose-lowering mechanism of action. Biguanides and thiazolidinediones are often categorized as insulin sensitizers due to their ability to reduce insulin resistance. Sulfonylureas and meglitinides are often categorized as insulin secret agogs because they enhance endogenous insulin release. New options for implementation of insulin therapy are now available. Rapid-acting insulins, that is Lispro and Aspart, are available in insulin mixtures, marketed as Humalog Mix 75/25 and Novolog Mix 70/30, and the long-acting basal insulin glargine has increased the ease of implementation of intensive insulin therapy for many patients. Glulazine, another rapid-acting insulin analog, has received Food and Drug Administration (FDA) approval for treatment of type 1 and 2 diabetes mellitus, and is expected to be marketed in 2005. Research on alternative delivery of insulin through inhalation or oral routes is continuing, though the latest information targets 2005 or 2006 as a likely time frame for the earliest FDA approval of a product. The subsequent sections describe the current antidiabetic medications that are available to treat type 1 and type 2 diabetes mellitus. We will now consider drug class information. Let's begin with insulin. Pharmacology. Insulin is an anabolic and anticatabolic hormone. It plays major roles in protein, carbohydrate, and fat metabolism. For a complete review of insulin action, the reader is referred to a diabetes physiology text. Endogenously produced insulin is cleaved from the larger proinsulin peptide in the beta cell to the active peptide of insulin and C-peptide, which can be used as a marker for endogenous insulin production. All commercially available insulin preparations contain only the active insulin peptide. Next we will look at their characteristics. Characteristics that are commonly used to categorize insulins include source, strength, onset, and duration of action. Additionally, insulins may be characterized as analogs, defined as insulins that have had amino acids within the insulin molecule modified to impart particular physiochemical and pharmacokinetic advantages. Table 72.8 summarizes available insulin preparations. U100 and U500, 100 units per milliliter and 500 units per milliliter, respectively, are the strengths of insulin currently available in the United States. U500 regular insulin is available for individuals that may require large doses of insulin to control their diabetes. In the United States, all other insulins are available only in U100 strength. For some type 1 diabetes mellitus patients who require extremely low doses of insulin, dilution of U100 insulin to obtain accurate insulin doses may be necessary. Diluents and empty bottles can be obtained from the manufacturers for dilution. Historically, insulin came from either beef or pork sources. Beef insulin differs by 3 amino acids and pork by 1 amino acid when compared to human insulin. Manufacturers in the United States have discontinued production of beef and pork source insulins as of December 2003, and now exclusively use recombinant DNA technology to manufacture insulin. Eli Lilly and Aventis currently use a non-disease-producing strain of Escherichia coli for synthesis of human insulin, whereas Novo Nordisk uses Saccharomyces cerevisiae, or baker's yeast, for synthesis. Purity of insulin refers to the amount of proinsulin and other impurities present in a given insulin product. Prior to 1980, most insulin contained enough impurities, 300 to 10,000 ppm, to cause local reactions upon injection, as well as systemic adverse effects from antibody production. Modern technology has provided less expensive techniques to purify insulin. As a result, all insulin products contain equal to or less than 10 ppm of proinsulin. With purified preparations, all recombinant DNA human insulin and insulin analogs, containing less than 1 ppm of proinsulin. Regular crystalline insulin naturally self-associates into a hexameric, 6 insulin molecules, structure when injected subcutaneously. Before absorption through a blood capillary can occur, the hexamer must dissociate first to dimers, and then to monomers. This principle is the premise for additives such as protamine and zinc described below, and modification of amino acids for insulin analogs. Lispro, aspartate, and GLU-lysine insulins dissociate rapidly to monomers, thus absorption is rapid. Lispro, B28-lysine and B29-proline human insulin, monomeric, insulin with 2 amino acids transposed, aspartate, B28 aspartic acid human insulin, mono and dimeric, insulin with replacement of 1 amino acid, and GLU-lysine, B3-lysine and B29 glutamic acid, are rapidly absorbed, peak faster, and have shorter durations of action when compared to regular insulin. In comparison to human insulin, with an isoelectric point of 5.4, the analog glargine insulin, A21-glycine, B30A-arginine, B30A-L-arginine, and B30B-L-arginine human insulin, has an isoelectric point of 6.8. In the bottle, glargine is buffered to a pH of 4, a level at which it is completely soluble, resulting in a clear colorless solution. When injected into the neutral pH of the body, it rapidly forms microprecipitates that slowly dissolve into monomers and dimers which are then subsequently absorbed. The result is a long-acting, peakless, 24-hour duration insulin analog. Insulin analogs are modified human insulin molecules, and safety is paramount for FDA approval. Key factors that should be considered in the approval process include local injection reactions, antigenicity, efficacy compared to human insulin, insulin receptor binding affinity, and insulin-like growth factor 1 receptor affinity, which is compared to that of human insulin to determine mitogenic potential. Pause the video and carefully scrutinize Table 72.8 summarizing the available insulin preparations before advancing to the next slide. Pause the video and carefully scrutinize Table 72.8 summarizing the available insulin preparations before advancing to the next slide. We will now discuss the pharmacokinetics. Subcutaneous injection kinetics are dependent on onset, peak, and duration of action, and are summarized in Table 72.9. Absorption of insulin from a subcutaneous depot is dependent on several factors, including source of insulin, concentration of insulin, additives to the insulin preparations, e.g., zinc, protamine, etc., blood flow to the area, rubbing of injection area, increased skin temperature, and exercise in muscles near the injection site may enhance absorption, and injection site. Insulin is commonly injected in, from most rapid to slowest absorption, abdominal fat, posterior upper arms, lateral thigh area, and superior buttocks area. Insulin analogs, unlike other preparations of insulin, appear to retain their kinetic profile at all sites of injection. U500 regular insulin has a delayed onset and requires a lower dose when compared to U100 insulin. Addition of protamine, NPH, NPL, and aspartate protamine suspension, or excess zinc, that is lente or ultralente insulin, will delay onset, peak, and duration of the insulin's effect. Variability in absorption, inconsistent suspension of the insulin by the patient or healthcare provider when drawing up a dose, and inherent insulin action based on the pharmacokinetics of the products may all contribute to a labile glucose response. All insulin suspensions should be inverted or rolled gently at least 10 times to fully re-suspend the insulin. The half-life of an intravenous injection of regular insulin is about 9 minutes. Thus the effective duration of action of a single IV injection is short, and changes in IV insulin rates will reach steady state in approximately 45 minutes. Intravenous pharmacokinetics of other soluble insulins, Lispro, aspartate, glulisine, and even glargine, appear similar to IV regular insulin, but they have no advantages over IV regular insulin and are more expensive. Insulin is degraded in the liver, muscle, and kidney. Liver deactivation is 20% to 50% in a single passage. Approximately 15% to 20% of insulin metabolism occurs in the kidney. This may partially explain the lower insulin dosage requirements in patients with end-stage renal disease. The pharmacokinetics of the inhaled insulin products under development appear to be similar to those of rapid-acting insulin preparations, but inhaled insulin has not been released as of this writing. We will now discuss the efficacy. The efficacy of traditional insulins, e.g., regular, NPH, and lente insulins, is unequivocal. Insulin analog efficacy is measured via the same ways as traditional insulins. Insulin analogs in most studies have not shown superior HbA1c levels when compared to traditional insulins, but are often preferred by patients and practitioners. Lispro, aspartate, and glu-lysine are advantageous due to the ability to inject within 10 minutes of a meal, as compared to the recommendation to inject regular insulin approximately 30 minutes prior. Rapid-acting analogs have shown superior postprandial lowering of glucose when compared to regular insulin. Glargine insulin injected at bedtime has shown significantly less nocturnal hypoglycemia when compared to NPH injected at bedtime. An educated patient in conjunction with a skilled practitioner can achieve excellent glycemic control with insulin therapy. Efficacy with insulin therapy is related to achieving glycemic control while minimizing the risk of potential side effects, specifically hypoglycemia and weight gain. Insulin is recommended in patients with extremely high fasting plasma glucose levels, that is greater than 280 to 300 mg per deciliter, patients with ketonuria or ketonemia, symptomatic patients weight loss with polyuria, polydipsia, and/or nocturia, gestational diabetes mellitus, and if deemed appropriate by the clinician and patient. We will now look at the microvascular complications of diabetes mellitus. Insulin has been shown to be as efficacious as any oral agent for treating diabetes mellitus. The United Kingdom prospective diabetes study, which used sulfonylureas or insulin, showed equal efficacy in lowering the risk of microvascular events in newly diagnosed type 2 diabetes mellitus. Similarly, in type 1 diabetes mellitus, diabetes control and complications trial, abbreviated as DCCT, showed efficacy in reducing microvascular complications. Next we will discuss the macrovascular complications of diabetes mellitus. The connection between high insulin levels, hyperinsulinemia, insulin resistance, and cardiovascular events incorrectly leads some clinicians to believe that insulin therapy may cause macrovascular complications. The UKPDS and DCCT found no differences in macrovascular outcomes with intensive insulin therapy. One study, the Diabetes Mellitus, insulin glucose infusion in acute myocardial infarction study, reported reductions in mortality with insulin therapy. This group assessed the effect of an insulin glucose infusion in type 2 diabetes mellitus patients who had experienced an acute myocardial infarction. Those randomized to insulin infusion followed by intensive insulin therapy lowered their absolute mortality risk by 11% over a mean follow-up period of approximately 3 years. This was most evident in subjects who were insulin naive or had a low cardiovascular risk prior to the acute myocardial infarction. Pause the video and carefully scrutinize Table 72-9 summarizing the pharmacokinetics of various insulins administered subcutaneously before advancing to the next slide. We will now discuss the adverse effects. The most common adverse effects reported with insulin are hypoglycemia and weight gain. Hypoglycemia is more common in patients on intensive insulin therapy regimens versus those on less intensive regimens. Also, patients with type 1 diabetes mellitus tend to have more hypoglycemic events compared to type 2 diabetes mellitus patients. In the UKPDS study, performed over 10 years, the percentage of diabetic patients that needed assistance, third-party or hospitalization, due to a hypoglycemic reaction was 2.3%. The UKPDS reported a rate of 36.5% for risk of any hypoglycemic event, including mild, self-treated events. In the DCCT, tighter control produced a risk 3 times higher for severe hypoglycemia compared to conventional therapy. Glycemic goals should incorporate hypoglycemic risk versus the benefit of lowering the glucose, when HbA1c levels are near normal, especially in type 1 diabetes mellitus. Minimization of risk for patients on insulin should include education about the signs and symptoms of hypoglycemia, proper treatment of hypoglycemia, and blood glucose monitoring. Blood glucose monitoring is essential for those on insulin, and is particularly of value in patients with hypoglycemia unawareness. Patients with hypoglycemia unawareness do not experience the normal sympathetic symptoms of hypoglycemia, tachycardia, tremulousness, and sweating. Initial symptoms are often neuroglycopenic in nature, confusion, agitation, loss of consciousness, and/or progression to coma. Patients with hypoglycemia unawareness should check their blood glucose level prior to any activities that may be dangerous with a low blood sugar, e.g., driving and certain sports, among others. Proper treatment of hypoglycemia dictates ingestion of carbohydrates, with glucose being preferred. Unconsciousness is an indication for either IV glucose or glucagon injection, which increases glycogenolysis in the liver. Glucagon use would be appropriate in any situation in which the patient does not have or cannot have ready IV access for glucose administration. Education for reconstitution and injection of glucagon is recommended for close friends and family of a patient who has recurrent neuroglycopenic events. The patient and close contacts should be informed that it can take 10 to 15 minutes for the injection to start raising glucose levels, and patients often vomit during this time. Proper positioning to avoid aspiration should be emphasized. Weight gain is predominantly from increased truncal fat, and tends to be related to daily dose and plasma insulin levels present. Weight gain is undesirable in most type 2 diabetes mellitus, but may be seen as beneficial in underweight type 1 diabetes mellitus. Weight gain appears to be related to intensive insulin therapy, and can be somewhat minimized by physiologic replacement of insulin. The two forms of lipodystrophy, though less common today in people with diabetes mellitus, still occur. Lipohypertrophy is caused by many injections into the same injection site. Due to insulin's anabolic actions, a raised fat mass is present at the injection site with resultant variable insulin absorption. Lipoatrophy, in contrast, is thought to be due to insulin antibodies, with destruction of fat at the site of injection. Injection away from the site with more purified insulin is recommended, though several reports of lipoatrophy with lispro have been reported. We will now discuss drug-drug interactions. There are no significant drug-drug interactions with insulin, though other medications that may affect glucose control can be considered. Table 7210 lists common medications known to affect blood glucose levels. And now we will look at dosing and administration. The dose of insulin for any person with altered glucose metabolism must be individualized. In type 1 diabetes mellitus, the average daily requirement for insulin is 0.5 to 0.6 units per kilogram, with approximately 50% being delivered as basal insulin, and the remaining 50% dedicated to meal coverage. During the honeymoon phase it may fall to 0.1 to 0.4 units per kilogram. During acute illness or with ketosis or states of relative insulin resistance, higher dosages are warranted. In type 2 diabetes mellitus a higher dosage is required for those patients with significant insulin resistance. Dosages vary widely depending on underlying insulin resistance and concomitant oral insulin sensitizer use. Strategies on how to initiate and monitor insulin therapy will be described later in the therapeutics section. Next we will look at the storage of insulins. It is recommended that unopened insulins be refrigerated, that is at 36 degrees Fahrenheit to 46 degrees Fahrenheit prior to use. The manufacturer's expiration date printed on the insulin is used for unopened, refrigerated insulin. Once the insulin is in use, the manufacturer recommended expiration dates will vary based on the insulin and delivery device. Table 72.8 outlines manufacturer recommended expiration dates for room temperature, 59 to 86 degrees Fahrenheit, insulin. For financial reasons, Patients may attempt to use insulins longer than their expiration dates, but careful attention must be paid to monitoring glycemic control and signs of insulin decay, clumping, precipitates, discoloration, etc., if this is attempted. Pause the video and carefully scrutinize Table 7210 summarizing medications that may affect glycemic control before advancing to the next slide. Next we will discuss the sulfonylureas. Let's begin with their pharmacology. The primary mechanism of action of sulfonylureas is enhancement of insulin secretion. Sulfonylureas bind to a specific sulfonylurea receptor, abbreviated as SUR, on pancreatic beta cells. Binding closes an adenosine triphosphate-dependent potassium channel, leading to decreased potassium influx and subsequent depolarization of the membrane. Voltage-dependent calcium channels open and allow an inward flux of calcium. Increases in intracellular calcium cause translocation of secretory granules of insulin to the cell surface and resultant exocytosis of the granule of insulin. Elevated secretion of insulin from the pancreas travels via the portal vein and subsequently suppresses hepatic glucose production. Next we will look at the classification. Sulfonylureas are classified as first and second generation agents. The classification scheme is largely derived from differences in relative potency, relative potential for selective side effects, and differences in binding to serum proteins, i.e., risk for protein binding displacement drug interactions. First-generation agents consist of acetohexamide, chlorpropamide, tolazamide, and tolbutamide. Each of these agents is lower in potency relative to the second-generation drugs, glimepiride, glipizide, and gliburide, as shown in Table 7211. It is important to recognize that all sulfonylureas are equally effective at lowering blood glucose when administered in equipotent doses. Next we will discuss the pharmacokinetics of the sulfonylureas. All sulfonylureas are metabolized in the liver, some to active, others to inactive metabolites, see Table 7211. Cytochrome P450, CYP450, 2C9 is involved with the hepatic metabolism of the majority of sulfonylureas. Agents with active metabolites or parent drug that are renally excreted require dosage adjustment or use with caution in patients with compromised renal function. The half-life of the sulfonylurea also relates directly to the risk for hypoglycemia. The hypoglycemic potential is therefore higher with chlorpropamide and gliburide. The long duration of effect of chlorpropamide may be particularly problematic in elderly individuals, whose renal function declines with age, and therefore it has great potential for accumulation, resulting in severe and protracted hypoglycemia. Individuals at high risk for hypoglycemia, e.g., elderly individuals and those with renal insufficiency or advanced liver disease, should be started at a very low dose of a sulfonylurea with a short half-life. Hypoglycemia on low-dose sulfonylureas may dictate a short-acting insulin secretagogue, natglinade or repaglinade, in lieu of a sulfonylurea. We will now look at the efficacy of sulfonylureas. As mentioned earlier, when given in equipotent doses, all sulfonylureas are equally effective at lowering blood glucose. On average, HbA1c will fall 1.5% to 2%, with fasting plasma glucose reductions of 60 to 70 mg per deciliter. A majority of patients will not reach glycemic goals with sulfonylurea monotherapy. Patients who fail sulfonylurea usually fall into two groups: those with low C-peptide levels and high, that is above 250 mg per deciliter, fasting plasma glucose (FPG) levels. These patients are often primary failures on sulfonylureas, that is less than a 30 mg per deciliter drop of fasting plasma glucose, and have significant glucose toxicity or slow-developing type 1 diabetes mellitus. The other group is those with a good initial response, that is less than a 30 mg per deciliter drop of fasting plasma glucose, but which is insufficient to reach their glycemic goals. Over 75% of patients fall into the second group. Factors that portend a positive response include newly diagnosed patients with no indicators of type 1 diabetes mellitus, high fasting C-peptide levels, and moderate fasting hyperglycemia, that is less than 250 mg per deciliter. If glycemic goals are met, a secondary failure rate of approximately 5% to 7% per year can be expected. Next we will look at microvascular complications. Sulfonylureas showed a reduction of microvascular complications in type 2 diabetes mellitus patients in the UK-PDS. A more in-depth discussion follows later in the chapter. We will now look at the macrovascular complications of diabetes mellitus. In the largest study to date, the UK-PDS, no significant benefit or harm was seen in newly diagnosed type 2 diabetes mellitus patients given sulfonylureas over 10 years. The University Group Diabetes Program study documented higher rates of coronary artery disease in type 2 patients given tolbutamide, when compared to patients given insulin or placebo, though this study has been widely criticized. Some sulfonylureas bind to the SUR2A receptor that is found in cardiac tissue. Binding to the SUR2A receptor has been implicated in blocking ischemic preconditioning via potassium channel closure in the heart. Ischemic preconditioning is the premise that prior ischemia in cardiac tissue can provide greater tolerance of subsequent ischemia. Thus, patients with heart disease potentially have one compensatory mechanism to protect the heart from ischemia blocked. Conclusions are controversial and readers are referred to the pertinent articles for further discussion. Next we will discuss the adverse effects of sulfonylureas. The most common side effect of sulfonylureas is hypoglycemia. The pre-treatment fasting plasma glucose is a strong predictor of hypoglycemic potential. The lower the fasting plasma glucose is upon initiation, the higher the potential for hypoglycemia. Also, in addition to the high-risk individuals outlined in the pharmacokinetics section, those who skip meals, exercise vigorously, or lose substantial amounts of weight are also more likely to experience hypoglycemia. Hyponatremia, serum sodium 60 years, female gender, and concomitant use of thiazide diuretics. Weight gain is common with sulfonylureas. In essence, patients who are no longer glycosuric and who do not reduce caloric intake with improvement of blood glucose will store excess calories. Other notable, although much less common, adverse effects of sulfonylureas are skin rash, hemolytic anemia, gastrointestinal upset, and cholestasis. Disulfiram-type reactions and flushing have been reported with tolbutamide and chlorpropamide when alcohol is consumed. Pause the video and carefully scrutinize Table 7211 summarizing oral agents for the treatment of type 2 diabetes mellitus before advancing to the next slide. Pause the video and carefully scrutinize Table 7211 summarizing oral agents for the treatment of type 2 diabetes mellitus before advancing to the next slide. Pause the video and carefully scrutinize Table 7211 summarizing oral agents for the treatment of type 2 diabetes mellitus before advancing to the next slide. And now we will look at the drug interactions of sulfonylureas. Several drugs are thought to interact with sulfonylureas, and Table 7212 summarizes them by proposed mechanisms of action. Drug interactions from protein binding changes should occur shortly after the interacting medication is given, as the concentration of free, thus active, sulfonylurea will acutely increase. First-generation sulfonylureas, which bind to proteins ionically, are more likely to cause drug-drug interactions than second-generation sulfonylureas, which bind non-ionically. Of note, the clinical importance of protein-binding interactions has been questioned, as the majority of these drug interactions have been found to truly be due to hepatic metabolism. Drugs that are inducers or inhibitors of CYP452C9 should be monitored carefully when used with a sulfonylurea. Additionally, other drugs known to alter blood glucose should be considered. See Table 7210. Next we will discuss the dosing and administration. The usual starting dose and maximum dose of sulfonylureas are summarized in Table 7211. Lower dosages are recommended for most agents in elderly patients and those with compromised renal or hepatic function. The dosage should be titrated every 1 to 2 weeks. Use a longer interval with chlorpropamide to achieve glycemic goals. This is possible due to the rapid increase of insulin secretion in response to the sulfonylurea. Of note, immediate-release glipizid's maximal dose is 40 mg per day, but its maximal effective TIV dose is about 10 to 15 mg per day. The maximal effective dose of sulfonylureas tends to be about 60% to 75% of their stated maximum dose. Pause the video and carefully scrutinize Table 7212 summarizing drug interactions with sulfonylureas before advancing to the next slide. Next we will discuss short-acting insulin secretagogues. Let's begin with their pharmacology. Though the binding site is adjacent to the binding site of sulfonylureas, natglinade and repaglinade stimulate insulin secretion from the beta cells of the pancreas, similarly to sulfonylureas. Repaglinade, a benzoic acid derivative, and natglinade, a phenylalanine amino acid derivative, both require the presence of glucose to stimulate insulin secretion. As glucose levels diminish to normal, stimulated insulin secretion diminishes. And now we will look at the pharmacokinetics of short-acting insulin secretagogues. Both natglinade and repaglinade are rapid-acting insulin secretagogues that are rapidly absorbed, that is approximately 0.5 to 1 hour, and have a short half-life, that is 1 to 1.5 hours. Natglinade is highly protein-bound, primarily to albumin, but also to A1 acid glycoprotein. Nateglinide is predominantly metabolized by CYP2C9, 70%, and CYP3A4, 30%, to less active metabolites. Glucuronide conjugation then allows rapid renal elimination. Repaglinade is mainly metabolized by the CYP3A4 system to inactive metabolites that are excreted in the bile. Next we will look at the efficacy of short-acting insulin secretagogues. In monotherapy, both significantly reduce postprandial glucose excursions and reduce HbA1c levels. Repaglinade, dosed 4 mg 3 times a day, when compared to glyburide in diet-treated drug-naive patients reduced HbA1c levels less 1% versus 2.4%, from baseline, respectively. Natglinade, dosed 120 mg 3 times a day in a similar population reduced HbA1c values by 0.8%. The lower efficacy of these agents versus sulfonylureas should be considered when patients are greater 1% above their HbA1c goal. These agents can be used to provide increased insulin secretion during meals, when it is needed, in patients close to glycemic goals. Also, it should be noted that addition of either agent to a sulfonylurea will not result in any improvement in glycemic parameters. And now we will discuss their adverse effects. Hypoglycemia is the main side effect noted with both agents. Hypoglycemic risk appears to be less versus sulfonylureas. In part, This is due to the glucose-sensitive release of insulin. If the glucose concentration is normal, less glucose-stimulated release of insulin will occur. In two separate studies, nataglinide rates of hypoglycemia were 3% and repaglinide 15% versus glyburide and glipizide rates of 15% and 19%, respectively. Weight gain of 2 to 3 kg has been noted with repaglinide, whereas weight gain with nataglinide appears to be less than 1 kg. Next we will discuss the drug interactions. Glycemic control and hypoglycemia should be closely monitored when inducers or inhibitors of CYP3A4 are given with repaglinide. Gemfibrozil, a common medication used to treat hypertriglyceridemia in diabetes mellitus, more than doubles the half-life of repaglinide and has resulted in prolonged hypoglycemic reactions. Nataglinide appears to be a weak inhibitor of CYP2C9 based on tolbutamide metabolism, though no significant drug-drug interactions have been reported. Next we will discuss the dosing and administration. Nataglinide and repaglinide should be dosed prior to each meal, up to 30 minutes prior. The recommended starting dose for repaglinide is 0.5 mg in subjects with HbA1c below 8% or treatment-naive patients, increased weekly to a total daily dose of 16 mg, see Table 7211. The maximal effective dose of repaglinide is likely 2 mg with each meal, as a dose of 1 mg prior to each meal provides approximately 90% of the maximal glucose-lowering effect. Nataglinide should be dosed at 120 mg prior to meals, and does not require titration. A 60 mg dose is available, but the HbA1c decrement is small, 0.3% to 0.5%. If a meal is skipped, the medication can be skipped, and meals extremely low in carbohydrate content may not need a dose. Both agents may be used in patients with renal insufficiency, and offer an excellent alternative in patients experiencing hypoglycemia with low-dose sulfonylurea. Caution is advised for patients with moderate to severe hepatic impairment, as nataglinide has not been studied and the half-life is prolonged with use of repaglinide. We will move on to biguanides. Let's begin with their pharmacology. Metformin is the only biguanide available in the United States. Metformin has been used clinically for 45 years, and has been approved in the US since 1995. Metformin enhances insulin sensitivity of both hepatic and peripheral, that is muscle tissues. This allows for an increased uptake of glucose into these insulin-sensitive tissues. The exact mechanisms of how metformin accomplishes insulin sensitization are still being investigated, though adenosine 5' monophosphate activated protein kinase activity, tyrosine kinase activity enhancement, and glucose transporter 4 all play a part. Metformin has no direct effect on the beta cells, though insulin levels are reduced, reflecting increases in insulin sensitivity. We will now discuss the pharmacokinetics of biguanides. Metformin has approximately 50% to 60% oral bioavailability, low lipid solubility, and a volume of distribution that approximates body water. Metformin is not metabolized and does not bind to plasma proteins. Metformin is eliminated by renal tubular secretion and glomerular filtration. The average half-life of metformin is 6 hours, though pharmacodynamically, metformin's anti-hyperglycemic effects last longer than 24 hours. We will now discuss the efficacy of biguanides. Metformin consistently reduces HbA1c levels by 1.5% to 2.0%, fasting plasma glucose levels by 60 to 80 mg per deciliter, and retains the ability to reduce fasting plasma glucose levels when they are extremely high, that is greater than 300 mg per deciliter. The sulfonylureas' ability to stimulate insulin release from beta cells at extremely high glucose levels is often impaired, a concept commonly referred to as glucose toxicity. Metformin also has positive effects on several components of the insulin resistance syndrome. Metformin decreases plasma triglycerides and LDL-C by approximately 8% to 15%, as well increasing HDL-C very modestly, that is 2%. Metformin reduces levels of plasminogen activator inhibitor 1 and causes a modest reduction in weight, that is 2 to 3 kilograms. Next we will discuss the microvascular complications of biguanades. Metformin N equals 342 was compared to intensive glucose control with insulin or sulfonylureas in the UKPDS. No significant differences were seen between therapies with regard to reducing microvascular complications. We will now discuss the macrovascular complications of biguanades. Metformin reduced macrovascular complications in obese subjects in the UKPDS. Metformin significantly reduced all-cause mortality and risk of stroke versus intensive treatment with sulfonylureas or insulin. Metformin also reduced diabetes-related death and myocardial infarctions versus the conventional treatment arm of the UKPDS. Metformin should be included in the therapy for all type 2 diabetes mellitus patients, if tolerated and not contraindicated, as it is the only oral anti-hyperglycemic medication proven to reduce the risk of total mortality and cardiovascular death. Adverse effects. Metformin causes gastrointestinal side effects, including abdominal discomfort, stomach upset, and/or diarrhea in approximately 30% of patients. Anorexia and stomach fullness is likely part of the reason loss of weight is noted with metformin. These side effects are usually mild and can be minimized by slow titration. Gastrointestinal side effects also tend to be transient, lessening in severity over several weeks. If encountered, make sure patients are taking metformin with or right after meals, and reduce the dose to a point at which no gastrointestinal side effects are encountered. Increases in the dose may be tried again in several weeks. Anecdotally, extended-release metformin, marketed as glucophage XR, may lessen some of the GI side effects. Metallic taste, interference with vitamin B12 absorption, and hypoglycemia during intense exercise has been documented, but are clinically uncommon. Metformin therapy rarely, 3 cases per 100,000 patient years, causes lactic acidosis. Any disease state that may increase lactic acid production or decrease lactic acid removal may predispose to lactic acidosis. Tissue hypoperfusion, such as that due to congestive heart failure, hypoxic states, shock, or septicemia, via increased production of lactic acid, and severe liver disease or alcohol, via reduced removal of lactic acid in the liver, all increase the risk of lactic acidosis. The clinical presentation of lactic acidosis is often nonspecific flu-like symptoms, thus the diagnosis is usually made by laboratory confirmation. Metformin use in renal insufficiency, defined as a serum creatinine of 1.4 mg per deciliter in women and 1.5 mg per deciliter in men or greater, is contraindicated, as it is renally eliminated. Elderly patients, who often have reduced muscle mass, should have the glomerular filtration rate estimated by a 24-hour urine creatinine collection. If the calculated glomerular filtration rate is less than 70 to 80 milliliters per minute, metformin should not be given. Due to the risk of acute renal failure during intravenous dye procedures, metformin therapy should be withheld starting the day of the procedure and resumed in 2 to 3 days, when normal renal function has been documented. Next we will discuss the drug interactions of biguanades. C-metidine competes for renal tubular secretion of metformin, and concomitant administration leads to higher metformin serum concentrations. At least one case report of lactic acidosis with metformin therapy implicates C-metidine. Other drugs may interact similarly, such as procainamide, digoxin, quinidine, trimethoprim, and vancomycin. We will now look at the dosing and administration of biguanades. Metformin immediate release is usually dosed 500 mg twice a day, with the largest meals to minimize gastrointestinal side effects. Metformin may be increased by 500 mg weekly until glycemic goals or 2000 mg per day is achieved. See Table 7211. Metformin 850 mg may be dosed daily, and then increased every 1 to 2 weeks to the maximum dose of 850 mg 3 times a day, that is a total of 2,550 mg per day. Approximately 80% of the glycemic lowering effect may be seen at 1,500 mg, and 2,000 mg per day is the maximal effective dose. Extended-release metformin can be initiated at 500 mg a day with the evening meal and titrated weekly by 500 mg as tolerated to a single evening dose of 2000 mg per day. Twice daily to 3 times a day dosing of extended-release metformin may help to minimize gastrointestinal side effects and improve glycemic control. Metformin extended-release 750 mg tablets may be titrated weekly to the maximum dose of 2,250 mg per day, though as stated above, 1,500 mg per day provides the majority of the glycemic lowering effect. Next we will discuss thiazolidinediones. Let's begin with their pharmacology. Thiazolidinediones are also referred to as TZDs or glitazones. Hyperglitazone and rosiglitazone are the two currently approved thiazolidinediones for the treatment of type 2 diabetes mellitus. See Table 7211. Thiazolidinediones work by binding to the peroxisome proliferator activator receptor gamma, abbreviated as PPAR-gamma, which are primarily located on fat cells and vascular cells. The concentration of these receptors in the muscle is very low. Thus this is unlikely to be the main site of action. Thiazolidinediones enhance insulin sensitivity at muscle, liver, and fat tissues indirectly. Thiazolidinediones cause preadipocytes to differentiate into mature fat cells in subcutaneous fat stores. Small fat cells are more sensitive to insulin and more able to store free fatty acids. The result is a flux of free fatty acids out of the plasma, visceral fat, and liver into subcutaneous fat, a less insulin-resistant storage tissue. Muscle intracellular fat products, which contribute to insulin resistance, also decline. We will now discuss the pharmacokinetics of thiazolidinediones. Hyperglitazone and rosiglitazone are well absorbed with or without food. Both are highly, that is greater than 99%, protein-bound to albumin. Hyperglitazone is primarily metabolized by CYP2C8, and to a lesser extent by CYP3A4, that is 17%, with the majority being eliminated in the feces. Rosiglitazone is metabolized by CYP2C8, and to a lesser extent by CYP2C9, then conjugated with 2/3 found in urine and 1/3 in feces. The half-life of pyroglitazone and rosiglitazone is 3 to 7 hours and 3 to 4 hours, respectively. Two active metabolites of pyroglitazone with longer half-lives deliver the majority of activity at steady state. Both medications have a duration of anti-hyperglycemic action of over 24 hours. We will now discuss the efficacy of thiazolidinediones. Pyroglitazone and rosiglitazone, given for about 6 months, reduce HbA1c values approximately 1.5% and reduce fasting plasma glucose levels by approximately 60 to 70 mg per deciliter at maximal doses. Glycemic lowering onset is slow, and maximal glycemic lowering effects may not be seen until 3 to 4 months of therapy. It is important to inform patients of this fact and that they should not stop therapy even if minimal glucose lowering is initially encountered. The efficacy of both drugs is dependent on sufficient insulinemia. If there is insufficient endogenous insulin production, beta cell function, or exogenous insulin delivery via injections, neither will lower glucose concentrations efficiently. Interestingly, patients who are more obese, or who gain weight on either medication tend to have a larger reduction in HbA1c values. Pioglitazone consistently decreases plasma triglyceride levels by 10% to 20%, whereas rosiglitazone tends to have a neutral effect. LDL cholesterol concentrations tend to increase with rosiglitazone 5% to 15%, but do not significantly increase with pioglitazone. Both appear to convert small, dense LDL particles, which have been shown to be highly atherogenic, to large, fluffy LDL particles, that are less dense. Large, fluffy LDL particles may be less atherogenic, but any increase in LDL must be of concern. Both drugs increase HDL similarly, up to 3 to 9 mg per deciliter. Thiazolidinediones also affect several components of the insulin resistance syndrome. Plasminogen activator inhibitor 1, abbreviated as PAI1, levels are decreased, and many other adipocytokines are affected, endothelial function improves, and blood pressure may decrease slightly. Next we will discuss the microvascular complications of thiazolidinediones. Thiazolidinediones reduce HbA1c levels, which have been shown to be related to the risk of microvascular complications. And now we will discuss the macrovascular complications of thiazolidinediones. Macrovascular outcome studies are in progress. Thiazolidinediones improve endothelial function, raise HDL levels, slightly lower blood pressure, and have been shown to reduce restenosis after percutaneous transluminal coronary artery stenting. We will now look at the adverse effects of thiazolidinediones. Troglitazone, the first thiazolidinediones approved, caused idiosyncratic hepatotoxicity and had 28 deaths from liver failure, which prompted removal from the U.S. market in March 2000. Approximately 1.9% of patients placed on troglitazone had alanine aminotransferase, ALT, levels more than 3 times the upper limit of normal. The incidence, using these criteria for elevated liver enzymes, with pioglitazone, that is 0.25%, and rosiglitazone, that is 0.2%, has been low. No evidence of hepatotoxicity was reported in an analysis of more than 5,000 patients given rosiglitazone or pioglitazone. Several case reports of hepatotoxicity with rosiglitazone or pioglitazone have been reported, but improvement in ALT was consistently noted when the drug was discontinued. Prior to therapy, it is recommended that an ALT be checked. ALT monitoring vigilance has been lowered, and it is now recommended that the ALT be checked periodically at the practitioner's discretion. Prior guidelines recommended every 2 months for the first year of therapy, then periodically. Patients with ALT levels greater than 2.5 times the upper limit of normal should not start either medication, and if the ALT is greater than 3 times the upper limit of normal, the medication should be discontinued. Retention of fluid leads to many different possible side effects with rosiglitazone and pioglitazone. The etiology of the fluid retention has not been fully elucidated, but appears to include peripheral vasodilation and/or improved insulin sensitization with a resultant increase in renal sodium and water retention. A reduction in plasma hemoglobin, 2% to 4%, attributed to a 10% increase in plasma volume, may result in a dilutional anemia which does not require treatment. Edema is also commonly 4% to 5% in mono or combination therapy reported. When a thiazolidinedione is used in combination with insulin, the incidence of edema, approximately 15%, is increased. Thiazolidinediones are contraindicated in patients with New York Heart Association Class 3 and 4 heart failure, and great caution should be exercised when given to patients with Class 1 and 2 heart failure or other underlying cardiac disease, as pulmonary edema and heart failure have been reported. Edema tends to be dose-related, and if not severe, a reduction in the dose as well as use of diuretics will allow the continuation of therapy in the majority of patients. Weight gain, which is also dose-related, can be seen with both rosiglitazone and pioglitazone. Mechanistically, both fluid retention and fat accumulation play a part in explaining the weight gain. Thiazolidinediones, besides stimulating fat cell differentiation, also reduce leptin levels, which stimulate appetite and food intake. Average weight gain varies, but a 1.5 to 4 kg weight gain is not uncommon. Rarely, a patient will gain large amounts of weight in a short period of time, and this may necessitate discontinuation of therapy. Weight gain positively predicts a larger HbA1c reduction, but must be balanced with the well-documented effects of long-term weight gain. As a caution, anovulatory patients may resume ovulation on thiazolidinediones. Adequate pregnancy and contraception precautions should be explained to all women capable of becoming pregnant, as both agents are pregnancy category C. Next we will discuss the drug interactions of thiazolidinediones. No significant drug interactions have been noted with either medication. Neither pioglitazone nor rosiglitazone appear to be inhibitors or inducers of CYP3A4-HAVC8 or CYP2C8, CYP2C9, respectively, though drugs that are strong inhibitors or inducers of these pathways necessitate close monitoring. And now we will look at the dosing and administration of thiazolidinediones. The recommended starting dosages of pioglitazone and of rosiglitazone are 15 mg once daily and 2 to 4 mg once daily, respectively. Dosages may be increased slowly based on therapeutic goals and side effects. The maximum dose and maximum effective dose of pioglitazone is 45 mg, and rosiglitazone is 8 mg once daily, though 4 mg twice a day may reduce HbA1c by 0.2% to 0.3% more versus 8 mg once daily. Next we will discuss the alpha-glucosidase inhibitors. Let's begin with their pharmacology. Currently, there are two alpha-glucosidase inhibitors available in the United States, acarbose and miglitol. Alpha-glucosidase inhibitors competitively inhibit enzymes maltase, isomaltase, sucrase, and glucoamylase in the small intestine, delaying the breakdown of sucrose and complex carbohydrates. They do not cause any malabsorption of these nutrients. The net effect from this action is to reduce the postprandial blood glucose rise. Next we will discuss the pharmacokinetics of alpha-glucosidase inhibitors. The mechanism of action of alpha-glucosidase inhibitors is limited to the luminal side of the intestine. Some metabolites of acarbose are systemically absorbed and renally excreted, whereas the majority of miglitol is absorbed and renally excreted unchanged. Next we will discuss the efficacy of alpha-glucosidase inhibitors. Postprandial glucose concentrations are reduced 40 to 50 mg per deciliter, while fasting glucose levels are relatively unchanged. There is approximately a 10% reduction. Efficacy on glycemic control is modest, average reductions in HbA1c of 0.3% to 1%, affecting primarily postprandial glycemic excursions. Thus patients near target HbA1c levels with near normal fasting plasma glucose levels, but high postprandial levels, may be candidates for therapy. Regarding microvascular complications, alpha-glucosidase inhibitors modestly reduce HbA1c levels, which have been shown to be related to the risk of microvascular complications. Regarding macrovascular complications, the STOP-NIDDM study demonstrated that acarbose can decrease the conversion rate of impaired glucose tolerance to diabetes, as well as reduce the risk of cardiovascular events. Currently, no medication is FDA approved for the prevention of type 2 diabetes mellitus. Next we will discuss the adverse effects of alpha-glucosidase inhibitors. The gastrointestinal side effects, such as flatulence, bloating, abdominal discomfort, and diarrhea, are very common and greatly limit the use of alpha-glucosidase inhibitors. Mechanistically, these side effects are caused by distal intestinal degradation of undigested carbohydrate by the microflora, which results in gas, that is carbon dioxide and methane, production. Alpha-glucosidase inhibitors should be initiated at a low dose and titrated slowly to reduce gastrointestinal intolerance. BINO, an alpha-glucosidase enzyme, may help to decrease gastrointestinal side effects, but may decrease efficacy slightly. If a patient develops hypoglycemia within several hours of ingesting an alpha-glucosidase inhibitor, oral glucose is advised because the drug will inhibit the breakdown of more complex sugar molecules. Milk, with lactose sugar, may be used as an alternative when no glucose is available, as acarbose only slightly, that is 10%, inhibits lactase. Rarely, elevated serum aminotransferase levels have been reported with the highest doses of acarbose. It appeared to be dose and weight related, and is the premise for the weight-based maximum doses. And now we will discuss dosing and administration of alpha-glucosidase inhibitors. Dosing for both miglatol and acarbose are similar. Initiate with a very low dose, 25 mg with 1 meal a day, increase very gradually, over several months, to a maximum of 50 mg 3 times a day for patients equal to or less than 60 kg or 100 mg 3 times a day for patients above 60 kg, see Table 7211. Both alpha-glucosidase inhibitors should be taken with the first bite of the meal so that drug may be present to inhibit enzyme activity. Only patients consuming a diet high in complex carbohydrates will have significant reductions in glucose levels. Alpha-glucosidase inhibitors are contraindicated in patients with short bowel syndrome or inflammatory bowel disease, and neither should be administered in patients with serum creatinine above 2 mg per deciliter, as this population has not been studied. Next we will discuss pivotal trials. Let's begin with the Diabetes Control and Complications trial. Much of the last century in diabetes care was dominated by the debate over whether glycemic control actually was causative in complications of diabetes mellitus. Animal studies and some human studies suggested that the worse the glycemia, the greater the risk of complications. But the glucose hypothesis was not ultimately accepted as proven until the publication of the Diabetes Control and Complications trial in 1993. 1,441 patients with type 1 diabetes mellitus were divided into two groups: those without complications, that is 726 subjects, primary prevention, and those with early microvascular complications, that is 715 subjects, secondary prevention. These two groups were then again divided into two groups, 1 randomized to receive conventional therapy, 1 or 2 shots of insulin daily and infrequent SMBG with no attempt to change therapy based on home blood glucose readings, and the other to receive intensive therapy, 3+ injections of insulin daily or insulin pump, with frequent self-monitoring of blood glucose and alteration of insulin therapy based on self-monitoring of blood glucose results, plus frequent contact with a health professional. After 6.5 years mean follow-up with a difference in HbA1c between the two groups being approximately 2%, that is approximately 9% versus approximately 7%, retinopathy was decreased by 76% in the primary prevention cohort, with retinopathy progression reduced 54% in the secondary prevention group. Neuropathy was decreased by 60% in both groups combined. Microalbuminuria was decreased 39%, while macroproteinuria was reduced 54% with intensive therapy. Hypoglycemia was more common and weight gain greater with intensive therapy. A non-statistically significant reduction in coronary events was seen in the intensively treated group as compared to the conventional group. Follow-up studies 8 years after the diabetes mellitus control and complications trial ended continued to show an advantage of good glycemic control over what was previously considered conventional therapy. The diabetes mellitus control and complications trial revolutionized therapy of diabetes mellitus, demanding that stricter glycemic control be the goal. Let's now discuss the implications of the United Kingdom prospective diabetes study. The United Kingdom prospective diabetes study was a landmark study for the care of patients with type 2 diabetes mellitus, confirming the importance of glycemic control for reducing the risk of microvascular complications. More than 5,000 patients with newly diagnosed type 2 diabetes mellitus were entered into the study. Patients were followed for an average of 10 years. The major portion of the study assessed conventional therapy, no drug therapy unless the patient was symptomatic or had fasting plasma glucose greater than 270 mg per deciliter, versus intensive therapy starting with either sulfonylureas or insulin, aimed at keeping the fasting plasma glucose less than 108 mg per deciliter. A subset of obese patients was studied using metformin as the primary therapeutic agent. And now we will discuss a clinical controversy. Preservation of beta cell function, and thus arresting the progression of type 2 diabetes, appears to be the future goal of treatment. The United Kingdom prospective diabetes study clearly showed that sulfonylureas, metformin, and insulin are ineffective in stopping the progressive beta cell failure. In animal models, thiazolidinediones, abbreviated as TZDs, have been able to arrest beta cell failure, and in humans short-term indirect beta cell function measures have shown improvements. This could mean that thiazolidinediones arrest the progressive beta cell decline in type 2 diabetes mellitus. Based on these data and the large amount of indirect evidence showing that thiazolidinediones may be cardioprotective, some clinicians have started using thiazolidinediones as first-line therapy. Glucagon-like peptide-1-derived therapies have also shown promise in this area, though no agents are FDA approved at the face of this writing. Long-term studies are underway. Significant findings from the study include 1. Microvascular complications, predominantly the need for laser photocoagulation on retinal lesions, are reduced by 25% when median HbA1c is 7% as compared to 7.9%. 2. A continuous relationship exists between glycemia and microvascular complications, with a 35% reduction in risk for each 1% decrement in HbA1c. No glycemic threshold for microvascular disease exists. 3. Glycemic control has minimal effect on macrovascular disease risk. Excess macrovascular risk appears to be related to conventional risk factors such as dyslipidemia and hypertension. 4. Sulfonylureas and insulin therapy do not increase macrovascular disease risk. 5. Metformin reduces macrovascular risk in obese patients. 6. Vigorous blood pressure control reduces microvascular and macrovascular events. There was no evidence for a threshold systolic blood pressure above 130 mm of mercury for protection against complications. Beta blockers and angiotensin-converting enzyme inhibitors appear to be equally efficacious. We will now briefly look at therapeutics. Knowledge of the patient's quantitative and qualitative meal patterns, activity levels, pharmacokinetics of insulin preparations, and pharmacology of oral antidiabetic agents for type 2 diabetes mellitus are essential to individualize the treatment plan and optimize blood glucose control while minimizing risks for hypoglycemia and other adverse effects of pharmacologic therapies. We will now discuss type 1 diabetes mellitus. The choice of therapy for type 1 diabetes mellitus is simple. All patients need insulin. However, how that insulin is delivered to the patient is a matter of considerable practice difference among patients and clinicians. Historically, after the discovery of insulin by Banting and Best in 1921, frequent injections of regular insulin, initially the only insulin available, were given. Modifications of insulin led to longer-acting insulin suspensions and the use by many patients of 1 or 2 shots of longer-acting insulin each day. Because self-monitoring of blood glucose and HbA1c testing were not available at that time, patients and practitioners had no idea how well their patients' blood glucose concentrations were controlled, other than a vague sense from an indirect method, measurement of glucose in the urine. While the renal threshold for glucose is relatively predictable in young healthy subjects, it is highly variable in older patients and patients with renal disease. The advent of self-monitoring of blood glucose and HbA1c testing in the 1980s revolutionized the care of diabetes, enabling patients and practitioners to directly access blood glucose for assessment, and enabling the patient to make instantaneous changes in the insulin regimen if need be. Modern diabetes management would be impossible without these two tools. Contemporary management of type 1 diabetes mellitus attempts to match carbohydrate intake with glucose-lowering processes, most commonly insulin, as well as with exercise. Diet is still the cornerstone of diabetes therapy, but unlike in previous years, attempts are made to allow the patient to live as normal a life as possible. Understanding the principles of glucose input and glucose egress from the blood will allow the practitioner and the patient great latitude in the management of patients with type 1 diabetes mellitus. Simplistically speaking, one can break down normal insulin secretion into a relatively constant background level of insulin, that is basal, for the fasting and post-absorptive period, and prandial spikes of insulin after eating, that is, bolus, as shown in Figure 72-7. Insulin sensitivity and insulin secretion are not constant throughout the day, rendering the basal concept inaccurate. However, in most clinical situations, this approach provides a useful paradigm for understanding and applying insulin treatment for type 1 diabetes mellitus. The other basic principle to consider is that the timing of insulin onset, peak, and duration of effect must match meal patterns and exercise schedules to achieve near normal blood glucose values throughout the day. Historically, complexity of insulin regimens has usually been related to the number of injections of insulin administered per day. This is a reasonable classification. Clearly, one injection of any insulin preparation daily will in no way mimic normal physiology, and therefore is unacceptable. Similarly, 2 injections of any insulin daily will fail to replicate normal insulin release patterns. Injection regimens that begin to approximate physiologic insulin release start with split mixed injections of a morning dose of neutral protamine hagedorn, abbreviated as NPH, and regular insulin before breakfast, and again before the evening meal. The presumption is made that the morning neutral protamine hagedorn insulin gives basal insulin for the day and covers the midday meal. The morning regular insulin covers breakfast. The evening NPH insulin gives basal insulin for the rest of the day, and the evening regular covers the evening meal. If patients are very compulsive about consistency of timing of their injections and meals and intake of carbohydrate, such a strategy may be successful. However, most patients are not sufficiently predictable in their schedule and food intake to allow tight glucose control with such an approach. The first modification that is frequently made to such a regimen is the movement of the evening neutral protamine hagedorn to bedtime, now 3 total injections per day, because the fasting glucose in the morning is too high. This approach improves glycemic control and reduces hypoglycemia, sufficiently intensifying the insulin therapy for some patients. However, many patients need a more intense approach that also allows greater flexibility in their lifestyle. Pause the video and carefully scrutinize Figure 72.7 illustrating relationship between insulin and glucose over the course of a day and how various insulin regimens could be given before advancing to the next slide. The basal bolus concept is an attempt to replicate normal insulin physiology with a combination of intermediate-acting or long-acting insulin to give the basal component, and short-acting insulin to give the bolus component. Various strategies have been used for the former, including once or twice daily NPH, lente, or ultralente insulin, or once daily insulin glargine. Most patients require 2 shots of all of the above insulins except insulin glargine. Also, all of the above insulins, with the exception of insulin glargine, have some degree of peak effect that must be considered in planning meals and activity. Insulin glargine is a feasible basal insulin supplement for most patients with type 1 diabetes mellitus. The bolus insulin component is given before meals with regular insulin, lispro insulin, or insulin aspart. The rapid onset of action and short time course of lispro insulin and insulin aspart more closely replicate normal physiology. This approach allows the patient to vary the amount of insulin injected, depending on the preprandial self-monitoring of blood glucose level. The anticipated activity, upcoming exercise may reduce insulin requirement, and anticipated carbohydrate intake. Most patients will have a prescribed dose of insulin preprandially that they vary by use of a sliding scale. This type of adjusted scale insulin is intended to optimize the insulin regimen. In light of the negative connotation of the term sliding scale, usually referring to giving insulin only after the blood glucose increases, rather than treating the underlying disorder, a better descriptor for the adjusted dose insulin is variable dose prandial insulin or insulin algorithm. Carbohydrate counting is a very effective tool for determining the amount of insulin to be injected preprandially. Although general algorithms give rough guidelines, each patient will have to adjust the prescribed preprandial insulin dosage to achieve optimal glucose control. As a rough estimate, patients may be begun on approximately 0.6 units per kilogram per day with basal insulin 50% of total dose and prandial insulin 20% of total dose pre-breakfast, 15% pre-lunch, and 15% pre-supper. Type 1 diabetes mellitus patients generally require between 0.5 and 1 unit per kilogram per day. The need for significantly higher amounts of insulin suggests the presence of insulin antibodies or insulin resistance, coexistent endocrinopathy or type 2 diabetes mellitus. Obviously, insulin pump therapy, continuous subcutaneous insulin infusion, abbreviated as CSII, generally using Lispro or aspart insulin to diminish aggregation, is the most sophisticated form of basal bolus insulin delivery system. Continuous subcutaneous insulin infusion may be slightly more efficacious in achieving good glycemic control than multiple dose insulin injections. Extensive discussion of this mode of therapy is beyond the scope of this text. Nevertheless, the basic principles for implementation are the same. The one advantage of pump therapy is that the basal insulin dose may be varied, consistent with changes in insulin requirements throughout the day. In selected patients, this feature will allow greater glycemic control with continuous subcutaneous insulin infusion. However, insulin pumps require even greater attention to detail and frequency of self-monitoring of blood glucose than 4 injections daily. In appropriately selected patients willing to pay sufficient attention to detail of self-monitoring of blood glucose and insulin administration, continuous subcutaneous insulin infusion can be a very useful form of therapy. Intensive therapy, basal bolus, to all adult patients with type 1 diabetes mellitus at the time of diagnosis is recommended to reinforce the importance of glycemic control from the outset rather than change strategies over time after lack of control. Occasional patients with an extended honeymoon period may need less intense therapy initially, but should be converted to basal bolus therapy at the onset of glycemic lability. For patients insisting on 2 injections daily, NPH and regular insulin, starting at 0.6 units per kilogram with 2/3 in the morning, 2/3 of morning dose as NPH, and 1/2 of evening dose as NPH, may be sufficient. Regardless of the regimen chosen, gross adjustments in the total insulin dose can be made based on HbA1c measurements and symptoms such as polyuria, polydipsia, and weight gain or loss. Finer insulin adjustments can be determined on the basis of the results of frequent self-monitoring of blood glucose. All patients receiving insulin should have extensive education in the recognition and treatment of hypoglycemia. Yearly, or more often, questioning about the recognition of hypoglycemia is warranted. Documentation of frequency of hypoglycemia, particularly that requiring assistance of another person, visit to an emergent or urgent care facility, or hospitalization, should be recorded. In type 1 diabetes mellitus, the development of hypoglycemia unawareness is common. It may result from progression of disease with autonomic neuropathy. Loss of adrenergic warning signs in such a situation is a relative contraindication to intensive insulin therapy. More commonly, type 1 diabetes mellitus patients have loss of warning signs because of a presumed lower set point for release of counter-regulatory hormones as a result of frequent episodes of hypoglycemia. Hypoglycemia begets hypoglycemia. In such situations, more normal hypoglycemia awareness may be restored by a reduction or redistribution of the insulin dose to eliminate significant hypoglycemic episodes. A recent publication has found that short-term treatment with theophylline will improve hypoglycemia awareness. Whether this therapy should routinely be employed is still unknown. Children and pubescent adolescents are relatively protected from microvascular complications and must be managed with consideration of what is practical. Therefore, it is not unreasonable to use less intense management, that is 2 shots per day, premixed insulins, until the patient is postpubertal. Occasional patients have antibodies to injected insulin, but the significance of the antibodies is minimal. Human insulin therapy has not totally eliminated insulin allergies, although most patients have a local reaction that will dissipate over time. If the allergic reaction does not improve or is systemic, insulin desensitization can be carried out. Protocols for desensitization are available from major insulin manufacturers. While more common in the animal insulin era, lipohypertrophy is still seen in some patients with long-standing type 1 diabetes mellitus. Such patients give their insulin injections in the same site to minimize discomfort. Because insulin absorption from an area of lipohypertrophy is unpredictable, avoidance of injections into these areas is mandatory. Several common errors can occur in the therapy of patients with type 1 diabetes mellitus, causing erratic glucose fluctuations. 1. Failure to take into account peaks of insulin action when using a peaking insulin and planning meals and/or activity. Eating should be planned around the peaks of the insulin. 2. Random rotation of insulin injection sites. There is sufficient variability of insulin absorption from site to site that this practice alone may cause wide glucose swings. The most consistent absorption of insulin is from the abdominal wall. We try to get our patients to take all their injections in the abdomen. If the patient is unable or unwilling to follow this advice, then systematic site rotation is the next preferable option. The patient always gives the insulin injection in the same region of the body the same time of the day each day. For instance, the arms are always used every morning. Needless to say, the patient would not inject in a limb and then go out and exercise that limb, increasing blood flow and insulin absorption. 3. Overinsulinization is a very common problem. The answer to all high blood glucose is not necessarily more insulin, as the patient may be insulinopenic, or may be rebounding from a previous low glucose and treating it with excessive amounts of carbohydrate. Fastidious self-monitoring of blood glucose, particularly during the night, or selected use of continuous glucose monitoring, will help sort this out. Also, practitioners sometimes do not adequately differentiate type 1 diabetes mellitus from type 2 diabetes mellitus when using insulin. Patients with type 1 diabetes mellitus are insulinopenic but have normal insulin sensitivity. Patients with type 2 diabetes mellitus have varying degrees of insulin resistance. Therefore, 1 unit change in the dose of insulin for a patient with type 1 diabetes mellitus may have a dramatic effect on glucose concentrations, whereas in some patients with type 2 diabetes mellitus 10 to 20 times that amount of insulin may have little effect on glucose. Large changes in insulin dose in patients with type 1 diabetes mellitus are not usually indicated unless the patient's blood glucose control is very poor. Widely erratic self-monitoring of blood glucose results and/or weight gain often suggest overinsulinization. When in doubt, always double-check the patient's technique for insulin dosing, insulin injection, and self-monitoring of blood glucose. Sometimes the simplest of errors results in miserable glycemic control. Islet cell and whole pancreas transplantation are occasionally used in patients, usually renal transplants, who require immunosuppressive therapy for other reasons. There has been considerable interest in islet cell transplantation since investigators in Edmonton reported success without using glucocorticoids as immunosuppressive agents. Some of these patients are able to come off insulin altogether. Let's now move on to type 2 diabetes mellitus. Pharmacotherapy for type 2 diabetes mellitus has changed dramatically in the last few years with the addition of several new drug classes and recommendations to achieve more stringent glycemic control. Symptomatic patients may initially require treatment with insulin or combination oral therapy to reduce glucose toxicity, which may reduce beta cell insulin secretion and worsen insulin resistance. Patients with HbA1c approximately 7% or less are usually treated with therapeutic lifestyle measures with or without an insulin sensitizer. Those with HbA1c greater than 7% but 120% ideal body weight, without contraindications should be started on metformin titrated to approximately 2000 mg per day. Near normal weight patients may be treated with insulin secretagogues. Failure of initial therapy should result in addition rather than substitution, reserve substitution for intolerance to a drug due to side effects of another class of drug. For cost and efficacy reasons, metformin and an insulin secretagogue are often first and second line therapy. Initial oral combination therapy for patients with HbA1c greater than 9% to 10% should be considered, and several oral combination products Glucovance and Metaglip have been approved as a first-line treatment. Figure 72.8 is an algorithm developed by the Texas Diabetes Council for glycemic control. Thiazolidinediones may be substituted in situations in which a patient is intolerant of, or has a contraindication to, metformin as an insulin sensitizer. In the United Kingdom prospective diabetes study, insulin, metformin, or sulfonylureas did not halt beta cell failure. Thiazolidinediones, in a Zucker diabetic fatty rat model, preserved beta cell function. Short-term human studies have reinforced these results through indirect measures of beta cell function, and if similar results are found long-term, thiazolidinediones could become first-line therapy. For dual therapy, HbA1c reductions vary according to the medication added to the current therapy, Table 7213. After a patient has inadequate control on two drugs, adding a third class of oral agents, usually a thiazolidinedione, can be considered, though triple therapy is not presently FDA approved. Triple combination therapy with a sulfonylurea, metformin, and troglitazone was approved, but troglitazone is no longer available for use. An alternative is to add an intermediate-acting or long-acting insulin at bedtime, to the initial oral agent used or two-drug combination. Sulfonylureas are often stopped when insulin is added, but continuing the sulfonylurea is permissible until multiple daily injections are started, at which time it should definitely be discontinued. Virtually all patients with type 2 diabetes mellitus ultimately become relatively insulinopenic and will require insulin therapy. Insulin therapy for type 2 diabetes mellitus has changed dramatically in the last few years. Specifically, patients are often transitioned to insulin by using a bedtime injection of an intermediate or long-acting insulin, using oral agents primarily for control during the day. This strategy leads to less hyperinsulinemia during the day and is associated with less weight gain than the more traditional insulin strategies. Because most patients are insulin resistant, insulin sensitizers are commonly used with insulin therapy. Patients with type 2 diabetes mellitus are usually well buffered against hypoglycemia. Patients should be monitored for hypoglycemia by asking about nocturnal sweating, nightmares, both indicative of nocturnal hypoglycemia, palpitations, tremulousness, and neuroglycopenic symptoms, as well as self-monitoring of blood glucose. When bedtime insulin plus daytime oral medications fails, a conventional multiple daily dose insulin regimen while continuing the insulin sensitizers should be tried. Concerns and problems with insulin administration as addressed in the section on type 1 diabetes mellitus generally relate to the therapy of type 2 diabetes mellitus. However, patients with type 2 diabetes mellitus rarely have hypoglycemia unawareness. Also, the variability of insulin resistance means that insulin doses may range from 0.7 to 2.5 units per kilogram or more. Figure 72.9 is an algorithm for insulin therapy options in type 2 diabetes developed by the Texas Diabetes Council. The availability of short-acting insulin secretagogues, very short-acting insulin, and alpha-glucosidase inhibitors, all of which target postprandial glycemia, has reminded practitioners that glycemic control is a function of fasting and preprandial glycemia and postprandial glycemic excursions. Therefore, postprandial glucose measurements may need more emphasis if the HbA1c is near the glycemic goal. Currently, it remains to be seen whether targeting after-meal glucose excursions will have more of an effect on complications risk than more conventional strategies. Importantly, postprandial excursions proportionally contribute more than the fasting plasma glucose to the HbA1c percentage obtained as the HbA1c nears goals, and thus will need to be targeted for optimal glycemic control in many patients. In epidemiologic studies, post-glucose challenge glucose measurements are a better predictor of macrovascular disease risk and form the basis for American College of Endocrinology, American Association of Clinical Endocrinologists postprandial glycemic goals, see Table 72.7. Pause the video and carefully scrutinize Table 72.13 summarizing add-on dual therapy. Average HbA1c reductions before advancing to the next slide. Pause the video and carefully scrutinize Figure 72.8 illustrating glycemic control algorithm for type 2 diabetes mellitus in children and adults before advancing to the next slide. Next we will discuss special populations. Let's begin with children and adolescents with type 2 diabetes mellitus. Type 2 diabetes mellitus is increasing in adolescence. Obesity and physical inactivity seem to be particular culprits in the pathogenesis of this disease. Given the many years that the patient will have to live with diabetes, and recent evidence that the timeline for complications may mimic that of older adults, extraordinary efforts should be expended on lifestyle modification measures in an attempt to normalize glucose levels. Failing that strategy, the only labeled oral agent for use in children, aged 10 to 16 years, is metformin, though sulfonylureas are also commonly used in therapy. Thiazolidinediones have not been studied in children, but studies to ascertain safety and efficacy are currently underway. In adolescent females, the possibility of future pregnancy should be considered in the prescription of any drug regimen. Next we will look at elderly patients with diabetes mellitus. Elderly patients with newly diagnosed diabetes mellitus, almost always type 2 diabetes mellitus, present a different therapeutic challenge. Consideration of the risks of hypoglycemia in this population and the probable lifespan should help determine if less stringent glycemic goals should be set. Thinner, older patients may primarily be treated with shorter-acting insulin secretagogues, low-dose sulfonylureas, preferably not long-acting ones, or alpha-glucosidase inhibitors. Risk for lactic acidosis, which increases with older age and the age-related decline in renal function, makes metformin therapy more problematic. Thiazolidinediones may offer another alternative in patients in whom some weight gain is not unwelcome. Simple insulin regimens may be another easy approach to glycemic control in elderly patients with newly diagnosed diabetes mellitus. Next we will discuss gestational diabetes mellitus. Gestational diabetes mellitus is diagnosed as previously described. Dietary therapy to minimize wide fluctuations in blood glucose is of paramount importance. Intensive educational efforts are usually necessary. Pregnant women without diabetes mellitus maintain plasma glucose concentrations between 50 and 130 mg per deciliter. Frequent self-monitoring of blood glucose is needed to tell whether dietary interventions are successful. If fasting plasma glucose is greater than 105 mg per deciliter, or 1 hour postprandial plasma glucose levels are greater than 155 mg per deciliter, or if 2-hour postprandial plasma glucose levels are greater than 130 mg per deciliter, insulin therapy is usually begun. One shot of NPH or a mixture of NPH and regular insulin in a 2-to-1 ratio given before breakfast may be adequate to reach glucose targets. Titration of insulin and switching to more complicated regimens is guided by self-monitoring of blood glucose results. In spite of the long-standing labeling of sulfonylureas as contraindicated in pregnancy, one randomized, open-label, controlled trial evaluated the efficacy of glyburide as compared to insulin initiated after 11 weeks gestation. Adequate control of blood glucose was achieved as compared to traditional insulin therapy, with less hypoglycemia in the glyburide group. No evidence of any difference in complications, specifically cord serum insulin concentrations, incidence of macrosomia, caesarean delivery, or neonatal hypoglycemia between regimens were noted. Glyburide was not detected in the cord serum of any infant. As the study limited enrollment beyond 11 weeks gestation, no conclusions regarding teratogenicity can be made from this study. The ADA cites this study in a position paper and mentions its utility, but also warns that it is not a labeled use of the drug and suggests further studies are needed to establish its safety. Patients with gestational diabetes mellitus should be evaluated 6 weeks after delivery to ensure that normal glucose tolerance has returned. Because these patients' long-term risk for the development of diabetes mellitus is considerable, periodic assessment after that is warranted. And now we will look at special situations. Let's begin with sick days. Acute self-limited illness rarely presents a major problem for patients with type 2 diabetes mellitus, but can be a significant challenge for insulinopenic type 1 diabetes mellitus patients. While caloric intake generally declines, insulin sensitivity also decreases, meaning that it may take greater amounts of insulin to control blood glucose concentrations. Patients need to be adept at frequent self-monitoring of blood glucose, checking urine ketones, use of short-acting insulin, and understanding that sugar intake in this situation is not bad, but may be necessary to cover the insulin therapy given to keep the patient out of diabetic ketoacidosis. We encourage patients to continue the usual insulin regimen and to use supplemental rapid-acting insulin based on self-monitoring of blood glucose results, with further additional insulin given if ketonuria develops. Sugar and electrolyte solutions, such as sports drinks, can be used to maintain hydration, to provide needed electrolytes if there are significant gastrointestinal or urinary losses, and to provide sugar to keep the patient from developing hypoglycemia because of the extra insulin that is usually needed. In contrast, type 2 patients may need to switch to sugar-free drinks if blood glucose levels are continually elevated. Most patients can be taught how to sufficiently manage sick days and avoid hospitalization. Pause the video and carefully scrutinize Figure 72.9 illustrating an insulin algorithm for type 2 diabetes mellitus in children and adults before advancing to the next slide. Next we will discuss diabetic ketoacidosis and hyperosmolar hyperglycemic state. Diabetic ketoacidosis and hyperosmolar hyperglycemic state are true diabetic emergencies. A comprehensive discussion of their treatment is beyond the scope of this book. In patients with known diabetes, diabetic ketoacidosis is usually precipitated by insulin emission in type 1 diabetes mellitus, and intercurrent illness, particularly infection, in both type 1 and type 2 diabetes mellitus. However, patients with type 1 or type 2 diabetes mellitus, the latter being usually non-whites or Hispanics, may present at initial presentation. It is possible that some of the patients deemed to have type 2 diabetes mellitus actually have type 1 idiopathic diabetes mellitus. Patients with diabetic ketoacidosis may be alert, stuporous, or comatose at presentation. The hallmark diagnostic laboratory values include hyperglycemia, anion gap acidosis, and large ketonuria. Afflicted patients have fluid deficits of several liters and sodium and potassium deficits of several hundred milliequivalents. Restoration of intravascular volume acutely with normal saline, followed by hypertonic saline to replace free water, potassium supplements, and constant infusion insulin restore the patient's metabolic status relatively quickly. A flow sheet is often helpful in tracking the fluid and insulin therapies and laboratory parameters in these patients. Bicarbonate administration is generally not needed and may be harmful, especially in children. Treatment of the inciting medical condition is also vital. Hourly bedside monitoring of glucose and frequent monitoring, every 2 to 4 hours, of potassium is essential. Metabolic improvement is manifested by an increase in the serum bicarbonate or pH. Serum phosphorus usually starts high and plummets to lower than normal levels, though replacing phosphorus, while not unreasonable, is of questionable benefit in most patients. Fluid administration alone will reduce the glucose concentration, so a decrement in glucose values does not necessarily mean that the patient's metabolic status is improving. Rare patients will require larger amounts of insulin than those usually given, 5 to 10 units per hour. We double the patient's insulin dose if the serum bicarbonate has not improved after the first 4 hours of insulin therapy. Constant infusion of a fixed dose of insulin and the administration of intravenous glucose when the blood glucose level decreases to less than 250 mg per deciliter is preferable to titration of the insulin infusion based on the glucose level. The latter strategy may delay clearance of the ketosis and prolong treatment. The insulin infusion should be continued until the urine ketones clear and the anion gap closes. Long-acting insulin should be given 1 to 3 hours prior to discontinuing the insulin infusion. Intramuscular regular insulin or subcutaneous insulin Lispro or Aspart given every 1 to 2 hours can be utilized rather than an insulin infusion in patients without hypoperfusion. Patients may develop hyperchloremic metabolic acidosis with treatment if they have been given large volumes of normal saline in the course of their treatment. Such a situation does not require any specific treatment. Hyperosmolar hyperglycemic state usually occurs in older patients with type 2 diabetes mellitus, at times undiagnosed, or in younger patients with prolonged hyperglycemia and dehydration or significant renal insufficiency. A large ketonemia is usually not seen, as residual insulin secretion suppresses the production of ketones. Infection or another medical illness is the usual precipitant. Fluid deficits are usually greater and blood glucose concentrations higher, at times greater than 1000 mg per deciliter, in these patients than in patients with diabetic ketoacidosis. Blood glucose levels should be lowered very gradually with hypertonic fluids and low-dose insulin infusions, that is 1 to 2 units per hour. Rapid correction of the glucose levels, a drop greater than 75 to 100 mg per deciliter per hour, is not recommended, as it can result in cerebral edema. This is especially true for children with diabetic ketoacidosis. Mortality is high with the hyperosmolar hyperglycemic state. We will now talk about hospitalization for intercurrent medical illness. Patients on oral agents may need transient therapy with insulin to achieve adequate glycemic control. In patients requiring insulin, patients should receive scheduled doses of insulin with additional short-acting insulin. Sliding scale insulin is to be discouraged, as it is notorious for not controlling glucose and for sometimes resulting in therapeutic misadventures, with wide swings in the blood glucose as the patient bounces from hypoglycemia to hyperglycemia. In-hospital mortality is increased in many hyperglycemic conditions. Recent work documented a reduction in mortality in type 2 diabetes mellitus patients with acute myocardial infarctions who receive constant intravenous insulin during the acute phase of the event to maintain near normal glucose concentrations. In the case of cardiac ischemia, the beneficial effects may be a result of reducing free fatty acids or inflammation with insulin therapy. Similar mortality results have been documented in several intensive care unit settings using intravenous insulin and tight glucose control. Recently, the American College of Endocrinology released a position statement on inpatient glycemic control which recommended preprandial levels below 110 mg per deciliter, and postprandial levels below 180 mg per deciliter. It is prudent to stop metformin in all patients who arrive in acute care settings until full elucidation of the reason for presentation can be ascertained, as contraindications to metformin are prevalent in hospitalized patients. Next we will discuss perioperative management. Surgical patients may experience worsening of glycemia for reasons similar to those listed above for intercurrent medical illness. Patients on oral agents may need transient therapy with insulin to control blood glucose. In patients requiring insulin, scheduled doses of insulin or continuous insulin infusions are preferred. For patients who can eat soon after surgery, the time-honored approach of giving 1/2 of the usual morning NPH insulin dose with dextrose 5% in water intravenously is acceptable, with resumption of scheduled insulin, perhaps at reduced doses, within the first day. For patients requiring more prolonged periods without oral nutrition and for major surgery, such as coronary artery bypass grafting and major abdominal surgery, constant infusion intravenous insulin is preferred. Metformin should be discontinued temporarily after any major surgery until it is clear that the patient is hemodynamically stable and normal renal function is documented. And now we will look at reproductive age women and preconception care for women. An increasing prevalence of diabetes mellitus has been noted in reproductive age women. Pre-pregnancy planning is absolutely mandatory, as organogenesis is largely completed within 8 weeks, so good glycemic control should be obtained prior to conception. Unfortunately, major congenital malformations due to poor glucose control remain the leading cause of mortality and serious morbidity in infants of mothers with type 1 or type 2 diabetes mellitus. For women with diabetes mellitus controlled by lifestyle measures alone, conversion to insulin as soon as the pregnancy is confirmed is appropriate. For women with polycystic ovary disease who ovulate and become pregnant with insulin sensitizer therapy, conversion to insulin is mandatory as soon as pregnancy is confirmed. Insulin is the only acceptable pharmacologic therapy during pregnancy for women with diabetes mellitus in the United States. In Europe, metformin is sometimes used in pregnancy for type 2 diabetes mellitus, but its use is eschewed in the United States. Patients previously treated with insulin may need intensification of their regimen to achieve therapeutic goals. Normal pregnancy is associated with a decrease in the blood glucose concentration as fuel is diverted to the fetus. Pregnant patients will be ingesting both meals and snacks daily. Self-monitoring of blood glucose is generally intensified to try to reach glycemic targets and reduce fetal and maternal morbidity. Whether preprandial or postprandial glucose concentrations should be the target of therapy is hotly debated. Ketosis should be avoided, requiring urine monitoring for ketones in the morning and if the blood sugar is greater than 200 mg per deciliter. There has been some concern about the safety of insulin analogs in pregnancy, both for fetal development and advancement of microvascular complications. One study has shown no increase in retinopathy or progression of same with the use of insulin lispro in pregnancy. Next we will discuss special topics. We will begin with prevention of diabetes mellitus. Efforts to prevent type 1 diabetes mellitus with immunosuppressives or injected or oral insulin therapy have been unsuccessful. The Diabetes Prevention Program confirmed that modest weight loss in association with exercise can have a dramatic impact on insulin sensitivity and the conversion from impaired glucose tolerance to type 2 diabetes mellitus. In this study, approximately 2,000 individuals with impaired glucose tolerance were randomized to lifestyle changes, diet, exercise, and weight loss versus usual care. The study, which was originally planned to be ongoing for 5 years, was stopped after 2.8 years because the results were so conclusive. The usual care group developed diabetes at the rate of 11% each year. The lifestyle arm developed diabetes at a rate of 5% per year, a 58% reduction in the risk of developing diabetes. Surprisingly, a modest amount of diet and exercise yielded impressive results. The exercise program in the lifestyle group was walking 30 minutes 5 days each week. The mean weight loss over the 2.8-year study period was only 8 pounds. Similar results were seen in the Finnish diabetes study. In the diabetes prevention program discussed above, approximately 1,000 of the study patients were randomized to metformin therapy. The metformin-treated patients showed a 4-pound weight loss on average, and a reduction in the risk of developing diabetes of 31% compared to placebo. Interestingly, young and overweight individuals on metformin had a greater reduction in the risk of developing diabetes than normal weight and older study patients. The tripod study evaluated the ability of troglitazone to prevent the development of diabetes mellitus in women with a history of gestational diabetes mellitus. The rate of development of diabetes mellitus in the placebo arm of the study was approximately 12% per year, compared to about 5% in the treatment group. Total preservation of beta cell function was demonstrated over a 5-year period in women who had near normal beta cell function at baseline and who initially responded to the drug. The preservation of beta cell function was observed 8 months after the drug had been discontinued. It should be noted that no pharmacologic agents are currently FDA approved or recommended for prevention of type 2 diabetes mellitus, though prevention studies are underway using rosiglitazone, pioglitazone, natglinade, ramipril, and valsartan. We will now discuss a clinical controversy. Diabetes mellitus is associated with a substantially higher risk of morbidity and mortality. Pharmacologic prevention or delay of type 2 diabetes mellitus has been widely discussed since the release of the Diabetes Prevention Program results. Though lifestyle changes were more effective, with a 58% lower relative risk of progression to diabetes mellitus, metformin 850 mg twice a day reduced the risk by 31%. Acarbose, troglitazone, and orlistat all have been able to prevent or delay the onset of type 2 diabetes mellitus. Despite these data, there are no FDA-approved or ADA-recommended medications for the delay or prevention of type 2 diabetes mellitus. Medications require monitoring, can have serious side effects, and have been documented to be less effective than lifestyle changes. Despite this, many clinicians are giving high-risk patients medication for the delay or prevention of diabetes, in combination with lifestyle changes. We will now briefly look at patient education. It is not satisfactory to give patients with diabetes mellitus brief instructions with a few pamphlets and expect them to manage the disease adequately. Thinking that diabetes education is limited to 1 or 2 encounters is misguided. Education is a lifetime exercise. Successful treatment of diabetes mellitus involves lifestyle changes for the patient, e.g., medical nutrition therapy, physical activity, self-monitoring of blood glucose and possibly of urine for ketones, and taking prescribed medications. The patient must be involved in the decision-making process and must learn as much about the disease and associated complications as possible. Emphasis should be placed on the evidence that indicates that complications can be prevented or minimized with glycemic control and management of risk factors for cardiovascular disease. Recognition of the need for proper patient education to empower them into self-care has generated programs for certification in diabetes education. Certified diabetes educators, abbreviated as CDEs, must document their patient education hours and sit for a certification examination that assesses the knowledge, tasks, and skills of an educator in order to become certified. An increasing number of nurses, pharmacists, dietitians, and physicians are becoming certified diabetes educators to document to the public that they meet a minimum standard for diabetes education, and to fulfill quality initiatives in meeting guidelines for education recognition. We will now discuss treatment of concomitant conditions and complications. Let's begin with retinopathy. Patients with established retinopathy should see an ophthalmologist or optometrist trained in diabetic eye disease. A dilated eye exam is required to fully evaluate diabetic eye disease. Early background retinopathy may reverse with improved glycemic control. More advanced retinopathy will not regress with improved glycemia, and may actually worsen with short-term improvements in glycemia. Studies are underway to determine whether medical therapy independent of glucose control will prevent the development of advanced retinopathy. Laser photocoagulation has markedly improved sight preservation in diabetic patients. Next we will look at neuropathy. Peripheral neuropathy is the most common complication seen in type 2 diabetes mellitus patients in outpatient clinics. Paresthesias, numbness, or pain may be the predominant symptom. The feet are involved far more often than the hands. Improved glycemic control may alleviate some of the symptoms. If neuropathy is painful, symptomatic therapy is empiric, including low-dose tricyclic antidepressants, anticonvulsants, gabapentin, carbamazepine, and maybe phenytoin, duloxetine, venlafaxine, topical capsaicin, and various pain medications, including tramadol and non-steroidal anti-inflammatory drugs. Recently, another anticonvulsant, topiramate, has shown promise in the reduction of symptoms, with the positive side effect of weight loss in type 2 diabetes mellitus patients. The NUM variant of peripheral neuropathy is not treated with medication. Clinical manifestations of diabetic autonomic neuropathy include resting tachycardia, exercise intolerance, orthostatic hypotension, constipation, gastroparesis, erectile dysfunction, pseudomotor dysfunction, anhidrosis, heat intolerance, gustatory sweating, and/or dry skin, impaired neurovascular function, and hypoglycemic autonomic failure. Gastroparesis can be a severe and debilitating complication of diabetes mellitus. Improved glycemic control, discontinuation of medications that slow gastric motility, and the use of metoclopramide, preferably for only a few days at a time, or erythromycin may be helpful. Gastric pacemakers as therapeutic hardware are rarely used, though available. Orthostatic hypotension may require pharmacologic management with mineralocorticoids or adrenergic agonist agents. In severe cases, supine hypertension is extreme, mandating that the patient sleep in a sitting or semi-recumbent position. Patients with cardiac autonomic neuropathy are at a higher risk for silent myocardial infarction and mortality. The hallmark of diabetic diarrhea is its nocturnal occurrence. Diabetic diarrhea frequently responds to a 10 to 14-day course of an antibiotic such as doxycycline or metronidazole. In more unresponsive cases, octreotide may be useful. Erectile dysfunction is common in diabetes mellitus, and initial treatment should include a trial of one of the oral medications currently available to treat erectile dysfunction. People with diabetes often require the highest doses of these medications to have an adequate response. Pseudomotor dysfunction, as earlier defined, results in loss of sweating and resultant dry, cracked skin. Use of hydrating creams and ointments is needed. We will now discuss microalbuminuria and nephropathy. Diabetes mellitus, and particularly type 2 diabetes mellitus, is the biggest contributor statistically to the development of end-stage renal disease in the United States. The American Diabetes Association recommends a screening urinary analysis for albumin at diagnosis in persons with type 2 diabetes mellitus. Precise onset of type 2 diabetes mellitus can rarely be ascertained, and patients will often present at diagnosis with microvascular complications. In type 1 diabetes mellitus, microalbuminuria rarely occurs with short duration of disease or before puberty. Screening individuals with type 1 diabetes mellitus should begin with puberty and after 5 years, disease duration. There are 3 methods for assessing microalbuminuria. 1. Measurement of the urine albumin to creatinine ratio in a random spot collection, preferably the first morning void. 2. 24-hour timed collection. And 3. Timed e.g., 4-hour or 10-hour overnight collection. Microalbuminuria on a spot urine specimen is defined as a ratio of 30 to 300 mg per gram albumin, creatinine. On timed collections, microalbuminuria is defined as 30 to 300 mg per 24 hours or an albumin excretion rate of 20 to 200 micrograms per minute. Because of day-to-day variability, microalbuminuria should be confirmed on at least 2 of 3 samples over 3 to 6 months. Additionally, when assessing urine protein or albumin, conditions that may cause transient elevations in urinary albumin excretion should be excluded. These conditions include intense exercise, recent urinary tract infections, hypertension, short-term hyperglycemia, heart failure, and acute febrile illness. In type 2 diabetes mellitus, the presence of microalbuminuria is a strong risk factor for macrovascular disease and is frequently present at the time of diagnosis. Microalbuminuria may be a weaker predictor for future kidney disease in type 2 diabetes mellitus versus type 1 diabetes mellitus. Glucose and blood pressure control are most important for the prevention of nephropathy, and blood pressure control is the most important for retarding the progression of established nephropathy. Angiotensin-converting enzyme inhibitors and angiotensin receptor blockers, considered first-line recommended treatment modalities, have shown efficacy in preventing the clinical progression of renal disease in patients with type 2 diabetes mellitus. Diuretics frequently are necessary due to the volume-expanded state of the patient and are recommended second-line therapy. The American Diabetes Association and the National Kidney Foundation blood pressure goal of less than 130 systolic 80 diastolic can be difficult to achieve. 3 or more antihypertensives are often needed to treat goal blood pressures. Let's now talk about peripheral vascular disease and foot ulcers. Claudication and non-healing foot ulcers are common in type 2 diabetes mellitus patients. Smoking cessation, correction of lipid abnormalities, and antiplatelet therapy are important strategies in treating claudicants. Pentoxaphylline or CSEA-lostazole may be useful in selected patients. Revascularization is successful in selected patients. Local debridement and appropriate footwear and foot care are vitally important in the early treatment of foot lesions. In more advanced lesions, topical treatments may be of benefit. Diabetic foot care is an excellent example of the adage, An ounce of prevention is worth a pound of cure. Next we will look at coronary heart disease. The risk for coronary heart disease, abbreviated CHD, is 2 to 4 times greater in diabetic patients than in non-diabetic individuals. Coronary heart disease is the major source of mortality in patients with diabetes mellitus. Recent studies suggest that multiple risk factor intervention, lipids, hypertension, smoking cessation and antiplatelet therapy, will reduce the burden of excess macrovascular events. Epidemiologic data suggest that coronary heart disease prevention guidelines for type 2 diabetes mellitus apply equally to patients with type 1 diabetes mellitus. Beta blocker therapy supplies an even greater protection from recurrent coronary heart disease events in diabetic patients than in non-diabetic subjects. Masking of hypoglycemic symptoms is a greater problem in type 1 diabetes mellitus patients than in patients with type 2 diabetes mellitus. Pause the video and carefully scrutinize Table 72:14 summarizing classification of lipid and lipoprotein levels in adults before advancing to the next slide. Next we will discuss lipids. The Scandinavian simvastatin survival study showed 42% reduction in coronary heart disease events in diabetic patients with known coronary heart disease and very high LDL cholesterol levels with simvastatin therapy, mean dose, 27 mg per day with LDL cholesterol reduction of approximately 35%. Lesser degrees of risk reduction have been shown in other secondary prevention studies in patients treated with pravastatin with mild to moderate LDL cholesterol elevation at baseline. The Heart Protection Study randomized 5,963 patients age above 40 years with diabetes and total cholesterol greater than 135 mg per deciliter. A significant 22% reduction, 95% confidence interval of 13 to 30, in the event rate for major cardiovascular events was seen with simvastatin 40 mg per day. This was evident even at lower LDL levels, less than 116 mg per deciliter, and suggests that approximately 30% reduction in LDL levels regardless of starting LDL levels may be appropriate. The diabetic subgroup in the Veterans Administration HDL intervention trial of coronary heart disease patients with low HDL cholesterol and low LDL cholesterol showed approximately 22% reduction in coronary heart disease events in diabetic patients with known coronary heart disease when HDL cholesterol was increased by approximately 6% by gemfibrozil. The new National Cholesterol Education Program Adult Treatment Panel 3, abbreviated NCEP-ATP, guidelines classify the presence of diabetes mellitus as a coronary heart disease risk equivalent, and therefore recommend that LDL cholesterol be lowered to less than 100 mg per deciliter. Unlike previous guidelines, more consideration is now given to HDL cholesterol and triglycerides. The primary target is the treatment of LDL cholesterol. After the LDL cholesterol goal is reached, usually with a statin, triglycerides are considered for pharmacologic management, assuming unresponsiveness to glycemic control efforts, weight management, and exercise. In such situations, a non-HDL cholesterol goal is established, a surrogate for all apolipoprotein B-containing particles. The non-HDL cholesterol goal for patients with diabetes mellitus is less than 130 mg per deciliter. Niacin or a fibrate can be added to reach that goal if triglycerides are 201 to 499 mg per deciliter. Niacin or a fibrate can also be added if the LDL cholesterol goal is reached, but the patient has low HDL cholesterol, that is less than 40 mg per deciliter. Patients with marked hypertriglyceridemia, equal to or greater than 500 mg per deciliter, are at risk for pancreatitis. Efforts to reduce triglycerides with glycemic control, elimination of other secondary causes, including medications, and drug therapy, fibrate and/or niacin, are effective treatment strategies. The American Diabetes Association also recommends similar LDL goals, but places raising HDL as the second priority, as shown Table 72-14. Next we will briefly discuss hypertension. The role of hypertension in increasing microvascular and macrovascular risk in patients with diabetes mellitus has been confirmed in the United Kingdom prospective diabetes study and hypertension optimization treatment trials. The American Diabetes Association recommends aggressive goals for blood pressure, less than 130 systolic 80 diastolic, in patients with diabetes mellitus. ACE inhibitors and angiotensin receptor blockers are generally recommended for initial therapy. The National Kidney Foundation also suggests that the blood pressure goal be less than 130 systolic 80 diastolic, as well as recommending diuretics as second-line therapy in patients with diabetic kidney disease. Many patients require multiple agents, on average 3 agents, to obtain goals, so diuretics, calcium channel blockers, and beta blockers frequently are useful as second and third agents. Blood pressure goals are generally more difficult to achieve than glycemic goals or lipid goals in most diabetic patients. We will now discuss a clinical controversy. Initial therapy choices for hypertension in diabetes mellitus usually include angiotensin-converting enzyme inhibitors or an angiotensin receptor blocker due to their well-documented renoprotective effects. Currently, angiotensin receptor blockers have less robust data to support cardiovascular reduction compared to other therapeutic choices, yet the data that exists appears to be positive in patients with type 2 diabetes mellitus. Also, diuretics have shown superior results to an angiotensin-converting enzyme inhibitor in the all-heart trial. The ADA currently recommends the use of any class angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, beta blockers, diuretics, or calcium channel blockers, of antihypertensive medication that has shown benefit in prevention of poor cardiovascular outcomes. Choice of monotherapy may not be important, as an average of 2 to 3 antihypertensive medications are needed to reach blood pressure goals. We will now briefly discuss transplantation. Whole pancreas and islet cell transplantation are still relatively experimental procedures in patients with type 1 diabetes mellitus. Those with end-stage renal disease also receive kidney transplantation. Next we will discuss pharmacoeconomic considerations. As described in the introduction, the direct and indirect costs of diabetes mellitus are substantial. Much of the indirect costs are related to loss of productivity due to the significant morbidity, hospitalizations, loss of vision, lower extremity amputations, kidney failure, and cardiovascular events associated with the disease. For a disease that affects only 5% to 6% of the population, it is responsible for 11% to 12% of health expenditures. With evidence from the Diabetes Control and Complications Trial and United Kingdom prospective diabetes study to support intensive blood glucose control to reduce the risk of complications, the question of cost-effectiveness comes into play. An economic model based on the Diabetes Control and Complications Trial approximates that 120,000 persons in the US would meet criteria for intensive intervention. The cost of implementing intensive therapy over the lifetime of the population is estimated at $4 billion. The benefits of this strategy are net gains of 920,000 years of sight, 691,000 years free from end-stage renal disease, and 678,000 years free from lower extremity amputations. The incremental cost per year of life gained is $28,661. This is well within the limits of a cost-effective strategy and compares favorably to treatment of high blood pressure or hypercholesterolemia. Economic analysis of intensive therapy for type 2 diabetes mellitus is more complex. Outcomes must also factor in the burden of cardiovascular disease as the major cause of mortality. One model analyzed the health benefits and economics of treating type 2 diabetes mellitus with the goal of achieving normoglycemia, but using outcomes based on the diabetes control and complications trial results. Accounting for the prevalence of cardiovascular disease in type 2 diabetes mellitus, an estimate of $16,002 incremental cost per quality-adjusted life year gained was obtained. The limitation of this analysis is that while the United Kingdom prospective diabetes study did demonstrate an improvement in diabetes-related outcomes, the overall efficacy on microvascular disease complications was not mirrored by the diabetes control and complications trial. Two economic analyses were performed on data generated from the United Kingdom prospective diabetes study, one assessing cost-effectiveness of an intensive blood glucose control policy in type 2 diabetes mellitus, and the other assessing improved blood pressure control in hypertensive patients with type 2 diabetes mellitus. In the first analysis, outcome was measured as the incremental cost per event-free year gained within the trial. Based on trial outcomes and assumptions, the incremental cost in the intensive treatment group per event-free year gained is $1,366. While intensive treatment costs were higher, the cost per event-free year gained appears cost-effective. The second analysis showed the incremental cost per extra year free from microvascular and macrovascular end points from intensive blood pressure control in a standard clinical practice model to be $1,498. The incremental cost per life year gained was estimated at $619, again demonstrating the cost-effectiveness of intensive intervention. And now we will discuss the evaluation of therapeutic outcomes. Let's begin with monitoring of the pharmaceutical care plan. A comprehensive pharmaceutical care plan for the patient with diabetes mellitus will integrate considerations of goals to optimize blood glucose control and protocols to screen for, prevent, or manage microvascular and macrovascular complications. In terms of standards of care for persons with diabetes mellitus, one can review the document published by the American Diabetes Association that outlines initial and ongoing assessments for patients with diabetes mellitus. For quality of care measures, one can refer to the National Diabetes Quality Improvement Alliance website at www.nationaldiabetesalliance.org, whose members include many of the governmental and physician organizations concerned with diabetes quality of care measures. The major performance measures should assess the ability to meet current standards of care and recognize the minimal treatment goals for glycemia, lipids, and hypertension, and provide targets for monitoring and adjusting pharmacotherapy as discussed in various sections above. Unfortunately, current publicly reported quality measures often fall short of current guidelines. Glycemic control, percentage of patients with less than percent, lipid, percentage of patients with LDL less than 130 mg per deciliter, and hypertension, percentage of patients with blood pressure less than 140 systolic 90 diastolic, quality measures are not congruent with the current goals recommended by the American Diabetes Association or American College of Endocrinology, American Association of Clinical Endocrinologists. Glycemic control is paramount in managing type 1 or type 2 diabetes mellitus, but as readily identified from the above discussion, It requires frequent assessment and adjustment in diet, exercise, and pharmacologic therapies. Minimally, HbA1c should be measured twice a year in patients meeting treatment goals on a stable therapeutic regimen. Quarterly assessments are recommended for those whose therapy has changed or who are not meeting glycemic goals. Fasting lipid profile should be obtained as part of an initial assessment and thereafter at each follow-up visit if not at goal, annually if stable and at goal, or every 2 years if the lipid profile suggests low risk. Documenting regular frequency of foot exams, each visit, urine albumin assessment, annually, dilated ophthalmologic exams, yearly or more frequently with identified abnormalities, and office visits for follow-up are also important. Assessment for pneumococcal vaccine administration, annual administration of influenza vaccine, and routine assessment for and management of other cardiovascular risks, i.e., smoking and antiplatelet therapy, are components of preventive medicine strategies. The multiplicity of assessments for each patient visit are likely to be better facilitated utilizing an integrative computer program, standardized progress note forms, or flow sheets, which assist the clinician in identifying whether the patient has met standards of care in the frequency of monitoring and achievement of defined targets of therapy. Thank you.